A very good morning to all of you, and I welcome you all on behalf of IMA Pune for MULTICON 2021. We are going to start now our session of scientific paper and poster presentation, mainly by the postgraduate students. We do have one UG student as well, and I welcome her as well. We have really great judges today. Two of them are head of the departments of the various institutes, medical institutes in Pune. I won't like to disclose their identities as of now. And one judge is from abroad of international repute, and her inputs would definitely help the postgraduate students for making their research papers more worth. So let's start with today's poster and paper presentation. Our third judge, being from Sassoon General Hospital, is slightly old, so she is going to join in 5 minutes from now. I'll just explain to you about.
I'm already joined.
Okay. Good morning. I would like to explain the rules for today's competition. Each candidate will have to screen share the PPT of their presentation. They'll get the time of 8 minutes each to present the paper or the poster. There will be 2 minutes for discussion where the judges are going to ask the questions to the candidate. Please do not present your paper for more than 8 minutes, though I'm not going to stop, but this rule should be followed. We have the order. As per the order, the first candidate would be Dr. Bhavana. So may I now request Dr. Bhavana to start her presentation, please. All three judges, I hope you are able to hear and see the presentation.
Yes, ma'am.
Ma'am, is everyone able to see the presentation?
Yes.
Yes, we can see you. We can hear you properly. Please go ahead.
Okay. Good morning. I'm Dr. Bhavna P, a final year pediatric resident from D.Y. Patil Medical College and Hospital. I'll be presenting a rare case report on childhood primary angiitis of the central nervous system. My case summary is of a 2-year-old female child who presented with first episode of right focal seizures followed by right-sided weakness since 1 day. She had a normal birth and developmental history. There was no history of fever, headache, vomiting or trauma and no history of any sensory deficits. Examination revealed a GCS of 15/15, decreased tone and power in the right upper and lower limbs of 2/5 and diminished deep tendon reflexes on the right side. Motor examination of the left side was normal. Sensory and cranial nerve examination revealed no abnormalities and clinical examination of other body systems was normal. A thorough investigation was done to look for the etiology of stroke. Routine blood tests including complete blood count, serum electrolytes and proteins, renal and liver function tests were done, which were normal. Coagulation profile revealed a prothrombin time of 12.3 and INR of 0.98, which were normal. Fasting lipid profile revealed a mildly elevated total cholesterol of 247 with normal LDL, triglycerides and HDL. A detailed prothrombotic or vasculitis profile, including lupus anticoagulants, ANA antibodies, ANCA antibodies, antiphospholipid and cardiolipin antibodies were done, which were negative. An MRI and MR angiography of the brain was done, which revealed an acute non-hemorrhagic infarct in the left frontal lobe with occlusion of the intracranial part of the left internal carotid artery and the supraclinoid segment of the right internal carotid artery. A contrast 2D echo was done to rule out thrombogenic foci and it was normal. The child was started on oral aspirin and simvastatin in view of raised cholesterol levels. She showed clinical improvement in the tone and power of the right upper and lower limbs to 3/5 within a week, and she was then discharged on oral ecosprin and statins. She was asymptomatic a month following discharge, after which she presented to our casualty with sudden onset of left-sided weakness and one episode of vomiting one day. Clinical examination this time revealed decreased tone and power on the left side of 2/5. The child was started on subcutaneous enoxaparin and IV Levipil to prevent progression of stroke. A repeat MR angiography and digital subtraction angiography was planned. MR angiography revealed acute non-hemorrhagic infarct in bilateral anterior cerebral artery this time, with severe narrowing of left intracranial internal carotid and right supraclinoid internal carotid artery, similar to the previous findings. Both common carotid and internal carotid artery were diffusely small in caliber. Digital subtraction angiography revealed stenosis of the C1 segment of cavernous internal carotid artery on both sides, with a 99% stenosis on the left side and 85% on the right side. A week later, she developed focal seizures of the right upper limb with deviation of mouth to the left. She was loaded with IV midazolam followed by IV Levipil. However, the seizures did not subside and she was shifted to the PICU in view of recurrent seizures and progression of stroke to right upper motor neuron facial palsy. These are images of her MR angiography and digital subtraction angiography, which reveals diffusely small caliber of branches of both the internal carotid arteries and increased area of infarct on the left side. A diagnosis of primary angiitis of the CNS was made based on clinical presentation, radiological features of vasculitis, and ruling out causes of secondary vasculitis. She was started on oral prednisolone at 1 mg per kg per day. Clinically, the child started showing signs of neurocognitive decline with loss of key milestones. She failed to recognize her parents with loss of eye contact, and there was no verbal response. She was then converted to IV methylprednisolone at 30 mg per kg per day. However, there was a deterioration of her neurological status with a drop in GC from 14 to 9/15. She started developing signs of raised intracranial tension in the form of bradycardia, bradypnea, and hypertension. This then led to the classification of the disease as progressive childhood primary angiitis of the CNS, and the decision to start pulse therapy of IV cyclophosphamide was taken. A single dose was given at 500 mg per meter square, slowly with continuous monitoring. Within 48 hours, the child showed improvement with resolution of signs of raised ICT and improvement in GCS to 11/15. Over the next few days, there was a dramatic improvement in the tone and power of left limbs to 4/5. She was able to stand by herself. She started making eye contact and recognizing her parents and expressing herself verbally. The child was later discharged with a plan to continue pulse dose of IV cyclophosphamide every month for a total of 6 months and to continue oral prednisolone for 1 month. Moving on to the discussion, childhood primary angiitis of the central nervous system is a rare but fatal cause of childhood stroke. Primary angiitis of the CNS previously has been described in adults, but only recently has it been identified in children. The diagnosis is based on modified Calabrese and Malik criteria, which are newly acquired focal or diffuse neurological or psychiatric symptoms in a patient less than 18 years of age, with characteristic angiographic or histopathological features of CNS angiitis and absence of underlying systemic disorder which can explain these features. It can be classified based on the vessel size into small vessel angiitis, which is angiography negative, and medium or large vessel, which is angiography positive. This can then further be divided into the progressive and non-progressive variant. These three subtypes have distinct symptoms and treatment outcome. The large or medium vessel manifests in the form of acute focal neurological deficits or a transient ischemic attack, whereas small vessel angiitis has a gradual onset of cognitive deterioration, changes in behavior and mood. In our case, the symptoms and course were consistent with the diagnosis of progressive medium vessel angiitis. There are no standard treatment guidelines for this disease. The primary aim is to control active intramural inflammation with high-dose corticosteroids, prevent secondary ischemic events with antithrombotic therapy, control associated neurological or psychiatric symptoms, and prevention of complications. The non-progressive variant is treated with boluses of methylprednisolone for 3 to 5 days, followed by high doses of oral prednisolone tapered over 3 months. The progressive variant treatment consists of an induction phase where high-dose corticosteroids for rapid control of inflammation are given for 1 month, then followed by monthly doses of IV cyclophosphamide for 6 months. This is combined with antithrombotic treatment. It is followed with a maintenance regimen with mycophenolate or azathioprine for 18 months. Conclusion. Childhood primary angiitis of the CNS is rare but can cause significant disability or death. Because of its rarity, acute and variable presentation, absence of standard diagnostic or therapeutic modalities, their diagnosis and effective management poses a challenge. It should be considered as a differential diagnosis in children presenting with focal or generalized CNS involvement, and it is a diagnosis of exclusion following detailed history, clinical assessment, radiological and blood investigations which rule out other entities to which the symptoms of the patient can be attributed. Timely initiation of immunosuppressive therapy has a favorable impact on the recurrence of new episodes and on the improvement of the symptomatology presented by the patient. Thank you.
Thank you, Dr. Bhavana. You can stop sharing your screen.
Thank you.
Yes, ma'am.
For a discussion from the judges. At the same time, I would like to request all other participants to keep yourself on mute, because when somebody is presenting and if you are not on mute, that disturbs the speaker and the audience. So kindly keep yourself mute when you are not speaking. So the topic is open for discussion. For the judges, you can ask the questions.
May I?
Yes.
Dr. Bhavna,
Yes, ma'am.
for such lucid and graphical presentation. Firstly, I would like to congratulate you for giving such an overall view. It really gave us a cinematic view of the entire case study till the discharge, I would say. But I would like to ask you one thing. Is it the diagnosis was possible because you had all the parameters for the diagnosis, and that is why it is said that it is rare? But maybe that's printing, but not getting diagnosed because of lack of infrastructure or the awareness. Is it so?
Pardon, ma'am.
Rare. Huh? So the incidence is rare in India or generally worldwide?
Ma'am, it's rare all over the world, ma'am. There are only 2 to 4 cases per million cases identified every year, ma'am.
Okay. So what was your motive of diagnosing it? I mean, how did you come to the exclusive?
Ma'am, mainly based on exclusion of all other systemic causes of vasculitis. We got her homocysteines done, thrombotic profile done, we got a 2D echo done, and we looked for any other cause of arteriopathy. All other possible causes of were negative in this patient. Any systemic manifestation like SLE, she didn't have any connective tissue disorders. There was no incidence of thrombosis also. Her homocysteine levels were evaluated, ANCA, ANA antibodies, all autoimmune workup was done, it was negative. Plus the radiological evidence of vasculitis in the MRI findings, along with her clinical statement.
Okay. Is there any genetic predisposition to the same condition in the family?
Ma'am, no, ma'am. The family, there's no family history of any similar stroke episodes or anything. And very few studies have been done on the genetics. Only in adults, they have identified a gene called DOG8 gene, which has been known to be implicated in the etiology of this. But in children as such, no specific gene has been identified as such to cause this. Mainly, they're suspecting some immune-mediated damage with abnormal T cell activity, ma'am.
Thank you. Thank you, Mona.
Thank you,
Thank you,
Dr.
ma'am.
Bhavana. It was an excellent
Thank you, ma'am.
presentation. Other judges, do you wish to ask any questions? At the same time, I would like to request Dr. Dipti to mute yourself, because from your side there is disturbance for the speaker.
Yeah.
So,
I just have, I think I should commend Dr. Bhavna for presenting such a good case and so well. It was very clear and comprehensive. She's already talked about how she came to the differential diagnosis and all the investigations pointing to this rare diagnosis. Just an academic question, actually. What would be the prognosis in such a child? It was discussed that there would be neurological and psychiatric complications or sequelae. So what would be the possible?
Ma'am, actually, the prognosis, there are actually, like I mentioned, there are two varieties of this disease. One is the progressive form and non-progressive form. Usually the non-progressive form, they respond once they give IV pulse doses of corticosteroids. But the progressive form, they tend to have waxing and waning of symptoms in spite of corticosteroids. Sometimes they present with relapse of the same episodes. But very few studies are in this patient. We have actually given 2 doses of IV cyclophosphamide, and currently the child is at home, and she's walking around talking to her parents, and she's completely fine. It's been 3 months since she's been discharged, and she's had no relapse. So she wasn't responding initially to the methyl, but once we started IV cyclophosphamide, she's been responding, and she's not had any relapse since then. So mostly her prognosis seems to be good on immunosuppressive therapy.
Okay. Is there any risk of seizures? Just a final question, and then I'll.
Pardon, ma'am?
Is there a risk of seizures? Because she's had.
Yes, ma'am. Because of the infarct and the stroke-like episode, they have a risk of seizures. But usually, with continued treatment, the symptomatology starts decreasing in frequency and intensity. She actually had 2 episodes of seizures during her admission also.
Thank you, Dr. Bhavana, for excellent discussion, and I thank judges for the discussion. I again repeat, and this is my request to Dr. Ashish and Dr. Dipti to keep your mics on mute, because from your side it is getting disturbed for the speaker as well as for the judges. They are not able to listen to the candidates' answers properly. I again repeat, Dr. Ashish and Dr. Dipti themselves on mute. My sincere request to the presenter to keep only one device on. You are presenting simultaneously on 2 devices. There are echoes. We are not able to listen to clearly. Can you hear me, please? Please mute yourself. Can you hear me? Please mute yourself. Or otherwise, I'll request Piyush to mute everyone other than the person who is presenting. So now let's go to the next candidate, Dr. Sanika Timparkar. Dr. Dipti, please mute yourself. Dr. Ashish, please mute yourself. Dr. Sanika, you can start sharing your screen with your PPT.
Yes, I'm presenting a case of congenital generalized lipodystrophy, a rare cause of metabolic syndrome. Introduction. Congenital generalized lipodystrophy, or Bedinelli-Seep congenital lipodystrophy, is an autosomal recessive condition which is characterized by mutation in AGPAT2 or BSCL2 gene. Worldwide prevalence is 1 in 10 million. It is characterized by lack of adipose tissue in the body with muscular appearance and storage of fat in the muscle, liver, or heart. Insulin resistance is seen in 25% cases and hypertrophic cardiomyopathy in 20 to 25% patients. It is characterized by loss of adipose tissue, long extremities, acromegalic appearance, accelerated growth, hypertrophic cardiomyopathy, hepatosplenomegaly, insulin resistance, dyslipidemia. And this dyslipidemia is a risk factor for development of type 2 diabetes mellitus and cardiovascular disorders in such children. Our case was a 1-year-old male child, firstborn of third-degree consanguineous marriage, presented with progressive abdominal distension since 6 months, with uneventful perinatal history and apparently normal development. The child was exclusively breastfed for the first 6 months of life. There was no history of vomiting, loose stools, or no feed intolerance. There was no history of convulsions. Mother gave history of child having emaciated look since infancy. His anthropometric parameters revealed a short stature, height between 75th to 90th percentile, weight of 10 kgs, which was more than 75th percentile, head circumference of 44 centimeter, which was normal. All vital parameters were within normal limits. On examination, the child had a triangular facies, absent buccal pad of fat, curly coarse hair, muscular appearance, and there was generalized loss of fat over limbs, trunk, and hypertrophied muscles and prominent veins were seen. There was no acanthosis nigricans present. Abdominal distension was present with firm, massive hepatomegaly, 3 centimeters below the costal margin, with no splenomegaly. Genitals were normal and rest systemic examination was normal. Neurological examination was normal with normal intelligence. Investigations revealed a normal hemogram, normal blood sugar, elevated SGOT and SGPT, hypercholesterolemia, fasting lipid profile shows a HDL cholesterol of 20, LDL of 139, total cholesterol to HDL ratio was 9.2, and LDL to HDL ratio of 6.9, with a triglyceride level of 126. All other biochemical parameters were normal. USG abdopelvis revealed hepatomegaly with fatty infiltration of the liver. 2D echo was done to rule out any cardiomyopathy. It was normal. Neuroimaging was normal. Skeletal survey was done to rule out any dystosis multiplex. Liver biopsy revealed stratified hepatocytes with focal macrovesicular steatosis and impending cirrhosis. His genetic investigations revealed a BSCL2 gene mutation on exon 5, leading to congenital generalized lipodystrophy type 2, which was autosomal recessive. Discussion. Clinical presentation of our patient was consistent with Bernoulli-Seep congenital lipodystrophy type 2 variety. Diagnosis was confirmed by genetic testing. BSCL type 2 is a rare autosomal recessive disorder which is caused by mutation in the Seepin gene, which equally affects both males and females. BSCL1 is a less severe form and can present between second and third decade, whereas BSCL2 presents in the neonatal period, infancy, and early childhood. Major criteria for diagnosis are lipoatrophy, acromegaloid features, hepatomegaly, elevated serum triglycerides, and insulin resistance. Minor criteria are hypertrophic cardiomyopathy, psychomotor retardation, hirsutism, precocious puberty, and bone cysts. On chromosome 11q13, the BSCL2 gene, Seepin gene, is found within the 2.5 MB region, bordered by markers of D11S4076 and D11S4080. The Seepin gene is involved in creating lipid droplets and the development of adipocytes. Lipodystrophy manifests itself during birth or early childhood. One of the initial signs of lipodystrophies is a well-defined musculature with prominent superficial veins. At birth, anabolic characters such as enlarged visceral organs can be noted. Later in childhood, acanthosis nigricans appears on the large sections of skin, most notably on elbow, knees, and waist and axilla. Few patients develop diabetes during infancy, but more commonly, diabetes develops during adolescence. Hyperlipidemia usually precedes diabetes in these patients, and it is usually insulin resistance. Other features are acromegaloid features, lytic bone lesions may be present. The treatment of manifestations include limiting the total fat intake to 20 to 30% of the total dietary calories, keeps triglyceride blood concentrations normal. Leptin therapy is being considered in the treatment of CGL. Diabetes mellitus is handled similar to diabetes mellitus of juvenile onset. Regular screening for glycosuria is a sign of diabetes mellitus, which often begins in the teen age, but has also been documented in infancy. Monitoring for possible retinal, peripheral nerve, and renal consequences of diabetes mellitus, annual echocardiography or biannual liver ultrasounds to identify fatty infiltrates should be done. Genetic counseling is available. BSCL is an autosomal recessive disorder. Each sibling of an affected individual has a 25% risk of being affected, 50% probability of being an asymptomatic carrier, and a 25% chance of being unaffected and not a carrier at conception. Carrier testing of at-risk relatives and prenatal testing for high-risk pregnancies are both options if the pathogenic variant in the family are recognized. In conclusion, we can say that congenital lipodystrophy is a rare condition presenting with abnormal fat distribution and fatty liver and metabolic syndrome. Early detection and intervention for management of metabolic syndrome has definitive role in preventing future complications. Thank you.
Thank you, Dr. Sanika. It was an excellent presentation. May I request judges ask the questions, please? Yes, Dr. Sharma.
Dr. Sanika, can you hear me okay?
Yes, ma'am.
Thank you so much for the presentation. It was a very thorough review. My question to you was, what sort of counseling have you done of the family, considering that it is autosomal recessive, and you talked about, what the possible results of that could be? So what has been done so far?
Ma'am, we have counseled, this is their first pregnancy, so we counsel them to get genetic testing of the parents before the second pregnancy can be done, so that the possibility of having the second child, if it is related, can be ruled out for their next pregnancy, basically. Because the child is having the pathogenic variant, so it is very likely that the second child might be affected.
And are there any other family members, now that you have this diagnosis, when they look back, are there any other family members that there is a suspicion for a similar presentation?
No, ma'am. There was no positive family history in this patient.
Okay. And as of now, how is the child being treated? Are you considering leptin therapy, or just sort of monitoring the patient for any kind of metabolic abnormalities?
Ma'am, for now, we have just counseled, we haven't started leptin therapy. We have just asked him to keep screening for screening and following up regularly, and for diet restrictions mainly.
Okay, thank you so much.
Thank you.
Any other question from other judges, please? Okay, then we move to our next candidate. Dr. Ankit Kumar, have you joined because he was on duty?
Yeah, ma'am. Hello, ma'am.
Yeah, thanks for joining.
Yeah.
And you can start sharing your screen, please.
Sure, ma'am. Is it visible, ma'am?
Yes, it is visible. Yeah, go ahead.
Good morning, ma'am. Myself, Dr. Ankit, ma'am, resident anesthesia from AFMC Pune. Actually, I'm presenting here my thesis topic, which is the effect of intraoperative dextrose administration, post-operative nausea, vomiting in patient undergoing laparoscopic surgery. It's a randomized control trial, ma'am. It is presented by me, Dr. Ankit, and my faculty is Colonel Kiran, sir. Coming to the introduction, ma'am. As we know that the post-operative nausea vomiting is a major complication after laparoscopic surgery. We have seen that after each laparoscopic surgery, especially female going into laparoscopic surgery, came with the vomiting and nausea. The incidence is so high that it is around 50% for nausea, as well as the vomiting is 30% after giving the general anesthesia. PONV can lead to high level of patient distress, dissatisfaction, and may lead to increased healthcare cost. There is also increased recovery room time because the patient used to be there for more than 2 or 3 days. Especially, it will increase to 1 or 2. Definitely, it will increase to 1 or 2 days. Also expand the nursing care and need of overnight hospital admission. The oral glucose has been used through the age for the symptomatic relief of nausea and vomiting, but clinical studies show mixed results. I'm not able to. Yeah. The aim and objective of my study is to find the efficacy of intraoperative 5% dextrose administration on post-operative nausea vomiting in patient undergoing laparoscopic surgery. The objective is to compare the incidence of PONV with intraoperative 5% dextrose administration compared to the ringer lactate in patient undergoing laparoscopic surgery. The methodology, we included female patient age 18 to 45 years. All the patients are ASA1 and ASA2 who will be undergoing general anesthesia for elective laparoscopic gynecological and laparoscopic cholecystectomy surgery. The total number of patients taken in the study is 90, and the patient will be randomized into 2 groups, that is dextrose group, those patients who has given 5% dextrose, and the ringer lactate group. The patient start receiving an infusion of either 5% dextrose solution 500 ml or ringer lactate solution 500 ml 5 minutes before starting the general anesthesia inside the operation theater. Mandatory monitoring will be instituted, and pre-medication will be with fentanyl 1 mg per kg IV will be done. General anesthesia will be administered using propofol 2 mg per kg and atracurium as per our institutional protocol. The maintenance of the anesthesia will be done by the sevoflurane in the oxygen and nitrous in 50:50 proportion. Additionally, 0.5 max fentanyl will be administered for pain relief based on the patient requirement as assessed by the treating anesthesiologist. The study was conducted in AIMS and Command Hospital, Pune. The study was a prospective randomized control trial with a randomization done by the computer-generated random number table and allocation concealment by the sealed envelope technique. The institution ethical approval was also taken, and the written informed consent was taken from the patient. So we take these 2 parameters, the incidence of PONV in that is post-operative nausea vomiting for the first 24 hours post-surgery was calculated by on the Belleville scoring system, that is 0 is score for nausea and vomiting, 1 for nausea, 2 for nausea and belching, and 3 is for vomiting. The use of rescue antiemetic was recorded. Since the person who developed nausea or vomiting, we just give a rescue antiemetic, that is the ondansetron 4 mg IV. So coming to the result, we have seen that there is a reduced incidence of nausea and vomiting, especially the patient who has taken dextrose 5% compared to the patient who is on RL. Also, we have seen that the ondansetron 4 mg requirement is very less in the patient who has received 5% dextrose and compared to the patient who has given ringer lactate as IV. Coming to the discussion, demographic data was statistically similar. Out of 90 patients, 45 patients, that is 50% has developed PONV. As we have already said that the incidence is too high post laparoscopic surgery, there is a 50% chance of PONV in the patient going laparoscopic surgery. In group D1, that is the patient who has received dextrose, 21 patient, that is 46%, had developed PONV, while in the group RL, 24 patient has developed PONV within 24 hours of surgery. Although the p-value is not significant, that is 0.527, but there is overall reduction in post-operative nausea vomiting in D5 group in approximately reduction in 8%. Also, we have seen that the consumption of single dose of rescue antiemetic in dextrose group was also reduced when compared to that of the RL and NS. In this trial, perioperative, so the conclusion is that in this trial, perioperative administration of IV dextrose improved the PONV management as defined by reduction in the antiemetic rescue medication requirement. Yes, ma'am.
Thank you, Dr. Ankit Kumar.
Yeah.
The case is open, the paper is open for discussion. Dr. Shinde Madam is here.
Yes. Am I?
Yeah, sure, ma'am.
Okay. Yeah. Congratulations, Ankit.
Thank you, ma'am.
Ankit, I want to ask you, what is your take-home message after this clinical study? Is it a trial or is it a study?
It is a trial, ma'am. It's a randomized control trial. Actually, many of my friends has also done this trial, especially in AIMS. They find that since laparoscopic surgery, especially the female going for laparoscopic surgery, especially in cholecystectomy surgery or the DHL, diagnostic hydroscopic surgeries, so there they find that there is a high incidence of PONV in this patient, and every patient need antiemetic medication like metoclopramide or ondansetron, but just giving a 5% dextrose, which is a complex sugar, which the pathophysiology behind it is that it decreases the catabolism of the gut and reduce the peristalsis of the gut. So it will drastically reduce the need of antiemetic drug post-operatively, ma'am. And also there is a side effect of vomiting and nausea post-operatively because there is a chance of wound descent, delay wound healing, delay mobilization. So overall, just
I agree with you. I just want to ask you, laparoscopic procedure itself is a vomitogenic procedure.
Yeah,
okay? So you have omitted all antiemetics pre-operatively in this patient. In pre-medication?
In our institutional protocol, we have given 4 milligram ondansetron to all the patients.
What is your?
But since
so in this patient you are given?
Yeah, all the patient has been given pre-medication ondansetron as a pre-medication, but to avoid the PONV, ma'am, post-operative nausea, vomiting, that is the vomiting and nausea which occur within 24 hours post-surgery. Okay. In order to reduce that antiemetic doses, we have just given dextrose 5%, and we have found that there is a significant drop in the antiemetic needs.
Can it be equalized or compared with the ERAS protocol giving sugar solutions pre-operatively?
Yeah, it is consistent with that protocol also, ma'am, because the ERAS protocol also confirmed that the giving complex sugar, carbohydrate, and even the dextrose will decrease the vomiting.
What are the drawbacks or contraindications for this use of dextrose pre-operatively or peri-operatively?
Definitely, ma'am, the patient with the diabetic, since we have not taken, that has been excluded from my study. So the patient.
I'm asking about clinical applications in future if you want to give any message.
Overall,
that's a conditions or cases.
Only 50 grams of sugar, ma'am, in 500 ml of dextrose. I don't find that there is any contraindication because it will not cause that much hyperglycemia, which can lead to some diabetic ketoacidosis.
Which other group of patients who are intraoperatively are likely to cause nausea, vomiting, but you don't want to use sugar solutions? Which specialty of surgery?
Definitely the diabetic patient and I don't know.
Anything about neurosurgery?
Definitely, ma'am. Neurosurgery, I think, will avoid sugar solution.
Any reason for avoiding? It's a very simple question, actually.
It's increase the CMRO, ma'am, catabolic cerebral metabolic rate. So we have to avoid that because in order to decrease the CMRO, we are doing many things. So if the CMRO, that is cerebral metabolic rate, will increase, definitely there is a vasodilation there also, and there is a increase in intracranial pressure, ma'am.
But as of now, with your statistical test, there is no definitive advantage of 5%, though clinically you might think it's useful, right? So you need more and more studies with this.
I think, ma'am, many study has been done, and though there is not difference between incidence of PONV between two groups, but there is the study confirmed that there is a reduce in the antiemetic needs, ma'am, especially in the foreign country where the cost of expense of antiemetic drugs and ICU stay is high. So maybe this is the cheap method to just decrease the antiemetic need.
Thank you, Kiran, from my side. Thank you.
Yeah. Thank you, Dr. Ankit. I know you have another presentation, but that will take
No,
later.
ma'am, that is Major Ankit, ma'am.
Yeah. So kindly stop sharing your screen.
Yeah.
And I request now Miss Nande to share her screen and present her paper, please. Dr. Ankit, please stop sharing your screen.
Yeah, ma'am. I've already stopped, ma'am.
Ma'am, is my screen visible?
No, I can't see your screen. Please share your screen with your presentation. Pranava, please open your PPT, then minimize it, and then on Zoom platform, screen share, and then click your presentation. So first you have to open your PPT on your screen, minimize it, then go to Zoom, click the screen share option, and then click on your presentation. Then it will be seen.
Ma'am, what about now?
No, we are not able to see your presentation as of now. So Pranava, you can give a try. Till then, I'll take the next presenter, Dr. Nasir Shah. If you are ready with your presentation, you can start presenting. Pranava, till then, you just find out how you would be able to present your presentation through Zoom platform. Yes. Okay, Dr. Nasir, can we go to your presentation, please? I think Dr. Nasir is not. So Dr. Dipti, can you take your presentation now? Dr. Dipti?
Am I audible, ma'am?
Yes, Dr. Dipti, you are audible. So please start sharing your screen with your PPT. And I would request Pranava and Dr. Nasir Shah to be ready after Dr. Dipti's presentation.
Is it visible, ma'am?
Yes, it is visible. You please go to the slideshow.
Yes, ma'am. Morning, all. The topic is the affected. Hello, ma'am. Am I audible?
You are audible. Please go to show and hit the first slide.
Yes, ma'am.
And I think your two devices are open. So kindly one of them as mute because I can hear echoes from your side.
Yes, ma'am. Ma'am, right now it is okay?
No,
First slide.
Go to the first slide. Go to slideshow. Click slideshow on your screen. On your PowerPoint presentation, go to slideshow. You are on home. So go to slideshow. Click on the slideshow and click on the first slide.
Yes, ma'am. I'll just give it a try, ma'am. slideshow पे जाना है। Ma'am, is it okay now?
No, we can't see the slideshow. Okay, you go to the first slide and click the slides one by one. Because right now we can see only your thank you slide.
Okay, ma'am. I'll just give it a try.
Last slide.
You can scroll. You can scroll up.
Is it okay, ma'am, now?
Dipti, what I would suggest you stop sharing the screen and do it once again, because I think it
Right, ma'am.
so please stop sharing and again screen share the same presentation.
Right, ma'am. Right.
Mr. Piyush, can you help?
शो कहाँ पे था? इसका स्क्रीन शेयर हटाना है मुझे भी। इसको हटाना है, स्टॉप शेयरिंग ना। अरे यार मेरा नंबर चला गया।
क्या हो गया?
वो स्लाइड शो करने के लिए कह रहे थे।
इतना तो मुझे भी नहीं पता अभी पावर पॉइंट का।
यहाँ पे आ रहा है क्या?
It's on the lower right corner. There should be a little slide icon. Click on that.
ये है ना? मुझे यही पता है।
और क्या चाहिए था?
मुझे नहीं पता क्या चाहिए था।
This instruction to all the presenters. First, you should keep your PowerPoint presentation open on your laptop, minimize it, then go to the Zoom and then screen share, click screen share and then click on your minimized presentation so that it will be seen. Dr. Dipti, are you able to do that?
ठीक है, अब इसको ऐसे ही रहने देती हूँ ना। अंकित, इसको बैक करना है तो कैसे करेंगे? इसको नहीं, इसको ये ऐसे ही रहेगा ना?
आप आगे पीछे कर सकती हैं एरो से।
बस ठीक है ना, इसको अभी ऐसे ही रहने देती हूँ। चलो नेक्स्ट वाला देखते हैं।
Dr. Dipti, if it is taking time, I request Dr. Pranava, if you are ready with your presentation, please go ahead and screen share your presentation.
Ma'am, is it visible? Good morning, ma'am. Is it visible?
It is not.
No, not yet visible.
No, Pranama, no.
Just one.
Dr. Sharma has given you exact protocol how to go about in. They're very simple steps actually. Don't get stressed up. Just go one to the step.
Yeah, I'm again repeating. You open your PPT, minimize it, and then on Zoom platform, click the screen share option, and then click on your presentation, which is seen on the Zoom window. Then only your but we won't be able to see that. In case if it is not possible for you, then the last option is you are sent by email to IMA of Pune at gmail.com. But then from our side, it might be difficult for you to present. So I would suggest you should do it yourself. Okay, may I now request the next candidate, since Dr. Pranava, Dr. Dipti and Dr. Nasir Shah are not able to present. Dr. Shashidharan, can I request you to have your presentation, please? Dr. Shashidharan, are you there? Please unmute yourself.
Is he joined?
Yeah,
yes, ma'am, I'm here.
Yes.
I'm here, ma'am.
Can you please share your presentation?
Yes, ma'am, I'll do. Am I visible, ma'am?
Yes, it's visible. Go ahead.
Okay.
Yes.
Good morning.
Please go ahead with your presentation, sir.
Yes, ma'am. Good morning, everyone.
Yes, we can see and we can hear you.
Yes. I'm Dr. Shashidharan, physiology resident from AFMC Pune. The title of my paper presentation is, can neutrophil to lymphocyte ratio correctly predict the severity of COVID-19 disease, a cross-sectional study? The COVID-19 infection, a global pandemic declared by WHO on 11th March 2020, it started as pneumonia of unknown etiology in December 2019 in Wuhan, Hubei province of China. It's a highly infectious disease where the human-to-human transmission happened through the droplets that are generated while speaking, coughing, sneezing, and also by direct contact with the contaminated surfaces and fomites. In India, the epidemiological trends revealed two waves. The first wave between August and September 2020, and the peak of the cases seen in September, and the second wave between March to June 2021, with the peak of the cases in the late April and May 2021. There was flooding of the hospitals with not only the severe and the critical patients, but also the mild and asymptomatic patients, which made the patient management a Herculean task with the limited healthcare facilities that we have. There is a shortage of ICU beds, oxygen, essential medicines, and also the vaccines. A simple and easily available, cost-effective, reliable test to predict the prognosis was the need of the hour. The routine investigation, complete blood count, was used for this purpose. The neutrophil to lymphocyte ratio, platelet count, that are indicators of systemic inflammatory response, were evaluated as the predictor of COVID-19 disease severity and mortality. My research question is the neutrophil to lymphocyte ratio a correct predictor of the severity of COVID-19 disease? The primary objective was to determine whether the NLR ratio a correct predictor of severity of disease in COVID-19 patients. The study design is retrospective cross-sectional study. My study population are lab-confirmed patients of COVID-19 patients admitted to the hospital. The sample size is 253, of which 80 patients were females. The study location is Northern Bihar, state of India. The inclusion criteria, all the lab diagnosed COVID-19 patients, in whom the complete blood count was performed using hematology autoanalyzer on admission. The patients were categorized into mild, moderate, and severe categories based on the symptoms, their oxygen saturation, and respiratory rate. The PaO2 by FiO2 ratio was used to classify the severe ARDS patients into mild, moderate, and severe categories. This is as per the guidelines of the Ministry of Health and Family Welfare, Directorate General Health Services. From the complete blood count that has been done, the neutrophil to lymphocyte ratio was calculated, the platelet count was noted, and the values were compared among the mild, moderate, and the severe category of patients. Also, the values were compared between the survivors and the deceased patients. The statistical analysis part. The data was analyzed for normality by Shapiro-Wilks test, and ANOVA was applied for the parametric data, and for non-parametric data, Crystal Values test was used. The results are as shown in the table. This table shows the mean and standard deviation of the different variables among the mild, moderate, and the severe categories. The total number of mild patients were 171, and the moderate patients were 33, and the severe patients were 49. If we see the mean values of the NLR ratio, it is showing an increasing trend from 1.98 to 5.44 in the severe patients. Again, the age group, the mild patients were around, the mean age group is around 43, and for the moderate patients, it is around 50, and for the severe patients, it's around 60. The neutrophil count also increased with the increasing in the severity of the disease. The lymphocyte count showed a decrease in the increase in the severity of the disease, and the platelet count also showed an increase in the increase of the severity of the disease. This table shows the where the significance lies in the different parameters among the mild, moderate, and the severe categories. If you see the NLR ratio between the severe and the mild and moderate, the mean difference is statistically significant for the NLR. Also for the age, the mean difference is significant between the severe, mild, and moderate cases. The neutrophil count, again significant between the severe and the mild patients, but however, it is not significant, statistically significant between the severe and the moderate patients. The lymphocyte count again showed a significant difference between the severe and the mild patients. The platelet count again showed a significant increase in the severe patients as compared to the mild patients. This is a box and whisker plot showing the relation between the age and the severity, where the group 1, that is the mild patients, the average age group was, the mean age group is around 43. For the moderate patients, the mean age group is around 50. And for the severe category of patients, the mean age group is around 60. And this plot shows the relationship between the neutrophil to lymphocyte ratio and the severity. Among the mild patients, the value is around 2. For the moderate patients, it is around 3 to 4. And for the severe patients, the mean NLR ratio is slightly above 5. This table shows the comparison of the age and CBC parameters among the survivors and the deceased. Here we can see the age, neutrophil to lymphocyte ratio, and platelet counts are all high among the deceased patients as compared to the survivors, and the lymphocyte count is lower in the deceased patients as compared to the survivors. All of the parameters are statistically significant. Now, moving on to the discussion part, the mean age among the severe patients is 58.1 and the mild patients is 43.3. The mean age of the diseased patients is 63.5 and survivors is 46.5 years, suggesting the age as a risk factor for the severity and mortality in COVID-19 disease. The mean NLR among the severe patients and deceased are 5.44 and 7.16 respectively, as against the mean NLR in the mild patients and survivors, it is 1.98 and 2.74 respectively, suggesting again the elevated NLR is associated with increased severity and mortality in COVID-19 patients. The findings are consistent with the studies that were done in China, Italy by Young AP et al. Fuge et al., and Siculo A et al. Finally, to conclude, the neutrophil to lymphocyte ratio, the marker of systemic inflammatory response, can be used as a predictor of clinical severity of COVID-19 disease. The severity and mortality are higher among the older patients with higher NLR as compared to the younger patients with lower NLR. The old age and NLR, that is the neutrophil to lymphocyte ratio, can be considered as the independent predictors of the severity and mortality in COVID-19 patients. These are my references. Thank you, ladies and gentlemen, for the patient hearing.
Thank you, Dr. Shashidharan. It was a very excellent presentation. The topic is open for discussion. May I request the judges to ask the questions, please?
Okay, thank you, Shashidharan, for it shows you have done lots of COVID work. So hats off to you and congratulations.
Thank you.
Your studies from Bihar, right?
Yes,
I would like to ask you, what are the other physiological indicators for COVID severity as far as investigations are concerned?
Since they, yes, ma'am, the coagulation profile, because it's a hypercoagulable state, the coagulation profile, the inflammatory markers like CRP, D-dimer, ferritin, and these are the other markers that can be of help.
Okay. And what are the compounding factors, I would say, in the neutrophil lymphocyte ratio? What are the shortcomings?
This reading which I've taken is on admission. The reading should have ideally taken on the onset of the symptoms, and it has to be followed up during the stay of the patients, so that we can get dynamic changes in the neutrophil to lymphocyte ratio.
What other factors can change this cellular ratio?
The tumors, chronic infections,
yes,
can also affect the neutrophil to lymphocyte ratio.
Thank you, Sir. Thank you very much.
May I ask him a question? Though I'm not an expert, I'm an eye surgeon. Yes. But there was a study about blood group. So is there anything, this question can be for Shashidharan sir or for Surekha ma'am, who has worked a lot in COVID, that some blood groups have some kind of protection against COVID and some blood groups do not have. So is it true?
Yeah, I mean, let Shashidharan ask, then I will like to comment.
Okay. Mr. Shashidharan.
Ma'am, I have not come across a specific blood group being protected.
Yeah. Actually, on the contrary, we had a assumption that A positive is more susceptible for COVID infection, but somehow we have not been able to have any direct conclusion. But maybe after a few months, we get few studies from physiology as well as from clinical side. But as of now, we can't have a direct correlation.
Just a question. I mean, it was a very nicely presented case and very clear and significant conclusions, and for a very simple test. But then, as the age factor is there, would it not also be compounded by the fact that the older people will have more comorbidities? So that would be another factor for the disease or the severity of COVID infections, which we have known.
Yes, ma'am. The age itself is a confounding factor for this study, but I have not found any studies where it says that with age the lymphocyte counts goes down and the neutrophil counts goes high. And this is just a screening test to segregate the severe, mild, and moderate patients. So on a larger basis, it can be used for the identification of the severe patients.
Yes, of course. I mean, what I said is that there would also be other comorbidities that would also impact severity of illness in terms of age.
Yes, ma'am.
So apart
yes,
from that,
we have seen that the hypertensive and the diabetic patients and those who had chronic kidney disease, they were the patients who actually succumbed to disease with comorbidities.
Okay.
Dr. Shashidharan, could I ask one more question? Sorry.
Yes, yes, sure,
Yes,
you
ma'am.
can.
In your research, while you were, researching for this particular presentation, did you come across the use of this ratio for any other viral or bacterial severe infections to predict the severity in those particular situations?
I came across the tumor. It is used for carcinomas of breast carcinomas and pancreatic carcinomas, and not specific infection. I didn't come across any specific infection.
Okay. Because mostly if it's acute infections, you will see a rise in neutrophils and a drop in lymphocytes, right? So I guess what I'm trying to get at is, based on your study, it looks like a ratio above 2 could be considered to predict more severity. So that would be in COVID-19. But what about, other viral or bacterial infections? Could we use this particular test with maybe a different ratio cutoff or so?
Yes.
Thank you, Dr. Shashidharan. Will you please
Thank you,
stop sharing your screen? It was an excellent
Yes.
presentation. And
Thank
before I go to our next candidate, that is Dr. Nasir, he's ready with his presentation. So we are going to give him the chance. Till then, I would like to express my gratitude to the judges who have given their special time for us. So because it is online, this is the first memento for Dr. Shinde Madam. Dr. Shinde Madam is the head of the Department of Anesthesiology in Sassoon General Hospital, and a lot of experience in COVID times. She has worked tremendously the whole scene of Sassoon, and we know how many cases were there was managed by she and her team. Thank you, Dr. Surekha Shinde Madam, for taking out time today. This is for you. Tomorrow, I would request you to come personally for the conference, and we would like to hand it over to you.
Thank you very much, Gitanjali.
Yeah, our second judge today is Dr. Jyoti Shetty Madam. Dr. Shetty Madam, can you just show your video, please? We would like, yes, here she is. She is the head of the Department of Psychiatry at Bharati Vidyapeeth Medical College. Tremendous experience in the field of psychiatry and research and papers. So many students of hers. This is a small memento for you, and thank you for joining from your busy schedule. She has joined from the hospital. Both of them have joined from their hospital. So thank you very much from IMA. Yes. And our final judge is, this is for you, Dr. Pranjali Sharma. She has joined from Parkview Medical Institute, Colorado, USA. She is the product of BJ Medical College, Pune, but then she opted for going for her residency in the USA, and she has done a lot of research methodology work and a lot of research in endocrinology. She is an endocrinologist faculty over there at Parkview. Thank you, Dr. Pranjali Sharma, for joining from Colorado, because I know it's night time over there. For India, it is morning, but for you, it is night time. So this is a small memento for you, and thank you for joining. And there is a sincere request by many young doctors from here that they would like to have your guidance for international presentations and for their papers. And IMA has specially requested you to help them as and when they need your help. Thank you for joining today. So Pranava, I'll take your paper later. Right now, Dr. Nasir Shah is ready with his presentation. So may I request him to share the screen, please, with his PPT.
Sorry, good morning, ma'am. There was power cut, so I was not able to. There was a problem in my network, ma'am.
No problem. Go to slideshow and can present it. We can hear you properly.
Ma'am, I'm resident of dermatology from Armand Porson Medical College, ma'am. Third year, ma'am. Today, my topic is marking nut dermatitis that is caused by semicorpus. It is a case series on infectious dermatitis. In India, we call it as a biloba. Botanical name is Semicorpus anacorium. It was commonly used in the Ayurvedic medicine for arthritis. It was used for rheumatism, and it was used in asthma. Biloba dermatitis is a common, usually causes common contact dermatitis. It causes eosinophil, which acts as both primary irritant and allergen. Eosinophil induces rash or type 4 hypersensitivity reaction, which have a symptoms such as itching, inflammation, oozing, and burning sensation. The sap of anacoriaceae or brown marking nuts can cause reaction within the period of 10 minutes. Sap from the blank mark nut reaction after 24 hours. I am presenting a case series. We came to, because we are in the medical college. There are many, they are from the Sikh regiment, which wants to, because there is a compulsory that they should be a turban and they should have a beard. And for the getting the excuse for that, they usually use this chemical to mimic other dermatological conditions so that they get excuse from the beard as well as the turban. So we came to a patient who was 27-year-old male who comes with the dermatology involvement of face, trunk, and upper extremities in the form of arterial plaques, bizarre crests, and crested erosion with black crests. And at the time of initial diagnosis, it was made that he is suffering from atopic dermatitis, and other differential was made as a contact dermatitis. When the whole history was taken, it was that he was using these marking nuts to create just like a mimic of other dermatitis. So we came to, during my studies, I came to have 5 patients like that who present us with the different presentations and who sometimes look like a seborrheic dermatitis, sometimes look like a photodermatitis. But when the history is properly taken, then we came to know that they are using this to have the excuse to get from the turban or the beard area, because in the Sikh regiment they have to have the beard as well as a turban. That is necessary, but to get of it, so they are using this sort of chemical marking nuts. So in nutshell, in the conclusion was below is a product of deciduous tree found in outer Himalayas, hotter parts of India, and closely related to cashew nuts. This plant is used as an anti-inflammatory, anti-arthritic, antioxidant, and anti-carcinogenic in Ayurvedic medicine. Bilumina was fruit shown as a mixture of cis and trans isomers of which acts as primary irritants and allergens. Erosional induces rashes or type 4 hypersensitivity reaction, and it persists for 2 to 3 weeks. And in rare cases, if the dose is more, it can result in the renal damage can occur, because if the dose is more than 5 to 10 grams, it can result in the renal damage as well as other cardiac problems can be resulted by this. And this is my posters, ma'am, and that is all. That is thank you, ma'am.
Thank you, Dr. Nasir. The presentation is open for discussion. The judges can ask the questions.
Thank you, Dr. Nasir. Sorry. Yeah.
Sorry,
Yeah.
Dr. Shetty.
Yeah, Dr. Pranjali. Yeah, Dr. Pranjali, you can go ahead. I'll ask afterwards.
Okay. Dr. Nasir, my question to you was there anything common between the 5 cases when on the dermatitis outside of the history that you had? Were there any common features because the same trigger or the same irritant was used?
Ma'am, trigger for this because it is commonly available, ma'am, and the accessible parts were only involved, not accessible central of the back was never involved in this patient. So it was giving us some sort of suspicious that they have taken, because when you are in the armed forces, so you came to know because people make such an excuses to get rid of duties, to get excuses in duties, and in some our forces in some regiments are there, they have a compulsory, they should have beard, they should wear turban, they should have long hairs, because to get excuse for that they are doing these sort of things, ma'am.
And when you mentioned that it can also cause renal failure, is that on ingestion?
Mostly, ma'am, because in Ayurvedic medicine, it is used as in rheumatism, in bronchial asthma, and if we take accidentally more than 5 to 10 grams of this, it can result in renal failure as well as cardiac abnormalities are there, ma'am.
Okay. Dr. Nasir, thank you for your presentation. Just a little bit of a clarification, because you said it's a case series on factitious dermatitis.
Yes, ma'am.
And being a psychiatrist,
Yes,
it comes under the realm of psychodermatology actually, because both psychiatrists and dermatologists see such patient presentations. So was there a psychiatry referral done? 2, when you say factitious, I mean it's understood that the person, for whatever reason, as you said, there was a secondary gain of this use of this nut for probably escaping duty, for presenting, or for whatever, simulating some sort of dermatological problems to escape that thing. So was there a psychiatric referral done, and if so, what was the management that was done? Is there any, I mean, being from the armed forces and the fact that these patients are obviously employed, I mean they're armed forces personnel, is there any punitive measures, and what is the actual management that is done for such cases?
Ma'am, because these for the personal gains, these people do it. But if we take it very seriously and we send these patients to the psychiatric, then it becomes an issue. So, ma'am, it becomes an issue in our system, ma'am. Then they get a Form 10, ma'am. Form 10, and they will get, because they are doing this activity of its own. They are applying to getting the benefit, though they will get a punishment. For that, we are just giving them counsel them and just leave them. Don't do it again. That is all. Because if we go by the procedure, then they will suffer the consequences. Though we are not going that way, ma'am.
Okay, fine. Thank you.
Okay.
Thank you, Dr. Nasir.
Thank you, ma'am. Thank you, ma'am.
I think you have another poster, or it is the same poster that you wanted to present?
Ma'am, it was other. I will not present this time, ma'am. Please.
Okay. No issues. Thank you, and you can stop sharing your screen, please.
Thank you, ma'am.
Yeah, Dr. Pranava, if you are ready with your presentation and if you have followed how to do it, see, you open your PPT, minimize it, then go to Zoom. There is a screen share option. You click on screen share and then click on your minimize presentation. Yes, perfect. Go ahead. I wish you all the best.
Thank you, ma'am. Good morning, everyone. I'm Pranava Nande, studying in 3rd year MBBS at BJ Medical College, Pune. My topic for today is epidemiology, clinical presentation, and management of COVID-19 associated mucormycosis, a single-center experience from Pune, Western India. This project was conducted under the guidance of Dr. Amit Dravid. The second wave of COVID in India, triggered by the Delta variant, has been associated with an unprecedented increase in the cases of COVID-19 associated mucormycosis. The burden of mucormycosis in the Indian population pre-COVID was 80 times the global prevalence, and this has increased exponentially during the second wave, with more than 10,000 cases reported in Maharashtra as of October 30th. CAM is an uncommon, rapidly progressive, angioinvasive, commonly fatal, opportunistic fungal infection caused by filamentous fungi of the order Mucorales and class Zygomycetes. Dysregulated immune response in COVID-19, characterized by exuberant activation of innate immune system, elevation in systemic inflammatory markers, and depleted adaptive immune response, predisposes individuals to CAM. In these patients, the activation of antiviral immunity to SARS-CoV-2 is known to paradoxically potentiate an inflammatory phenotype favoring secondary infections. Additionally, India has a nationwide prevalence of 7.3% for diabetes mellitus. The aims and objectives of my study were to understand the epidemiology, clinical presentation, outcomes, and long-term complications in patients with CAM, to categorize prevalence and potential risk factors in the cohort, the evaluation of baseline investigations and assessment of markers with respect to progression and outcomes, documentation of multidisciplinary diagnostic and therapeutic interventions administered during the treatment and outcomes, analysis of concomitant drugs and regimes administered during the COVID-19 treatment, and potential affiliations with the development of CAM, and identify baseline and time-dependent risk factors significantly associated with death due to CAM by relative risk analysis. This was a retrospective cohort study conducted at Noble Hospital and Research Center, Pune, between April 1st and 1st August. The data was obtained from electronic health records of each individual admitted for treatment of CAM by manual abstraction. Ethical approval was taken from the Institutional Ethics Committee. The data included hospitalization dates, demographics, comorbidities, severity of COVID-19, treatment received during COVID-19, presenting symptoms of mucormycosis, clinical examination data, diagnostic modalities including microscopy, culture, and histopath, as well as laboratory investigation. COVID-19 diagnosis was made in patients who tested positive for SARS-CoV-2 RNA in respiratory specimens by RT-PCR. The diagnosis and staging of mucormycosis was based on the revised definitions of invasive fungal disease of European Organization for Research and Mycosis Study Group. It was identified in patients having compatible clinical and radiological manifestations and demonstration of fungi in tissue or sterile body fluids. Continuous variables are summarized using median and interquartile range and compared using Mann-Whitney-U test. Categorical variables were summarized using frequency and percentages and compared using the chi-square, proportion, and Fisher's exact test. Baseline and time-dependent risk factors significantly associated with death due to CAM were identified by relative risk analysis. These were the baseline risk factors evaluated in detail, and these were the time-dependent risk factors. A p-value of less than 0.05 was considered as statistically significant, and data was analyzed using SPSS. Moving to the results and assessment. Out of 59 patients that were undertaken, 58 were diagnosed to have ROCM, while 1 had disseminated mucormycosis. 56 had pre-existing or newly diagnosed comorbidities. Diabetes mellitus was the most common seen in our cohort. The median age was 52 years, and 16 patients had mild COVID, 29 had moderate COVID, and 14 patients had severe or critical COVID disease prior to the diagnosis of mucormycosis. And 13 patients had received COVID vaccination prior to the administration. The drugs administered during the COVID treatment were charted as follows. Remdesivir was prescribed to 67.8%, and intravenous or oral steroids prescribed to 100%, and immune modulator therapy was prescribed to 22%. During the treatment of COVID-19, 33 patients were prescribed steroids in the absence of hypoxia for mild to moderate disease, categorizing as irrational or unscientific use of steroids. In 5 patients, methylprednisolone dose was given more than 2 milligrams per kg per day, and this was prescribed for severe COVID, which categorized as excess steroid dose, and 8.5% steroids were indicated in patients, but they were prescribed at an inappropriately high dose for moderate non-hypoxic COVID. The indiscriminate use of steroids in patients with mild or asymptomatic COVID-19 can be counterproductive, increasing susceptibility to opportunistic infections. Both the recovery trial and the WHO COVID-19 guidelines recommend against the usage of corticosteroids in COVID-19 patients who do not present with hypoxia, and despite that, indiscriminate use of steroid in mild COVID conditions continues in India. The improper use of COVID steroids has been identified as an independent risk factor for CAM by the Muco-COVID network. Baseline presenting characteristics for mucormycosis were documented, and the median duration from first positive RT-PCR test of mucormycosis was about 17 days, with an interquartile range of 12 to 22 days. Headache, hemifacial pain, predominantly maxillary pain, and facial swelling were the 3 most common presenting symptoms. Timely investigations were documented for monitoring and establishing associations in the cohort. The median CRP at admission was 84.7, and the median D-dimer and median ferritin value were also categorized. Aggressive surgical debridement of involved site and combination of antifungal therapy was a standard care used for all ROCM patients in the cohort. And complications during antifungal therapy and hospital administration are mentioned in the table. There were 14 deaths in our cohort during hospital administration for mucormycosis. On relative risk analysis, CT severity score during COVID-19 admission, presence of symptoms like eye swelling, loss of vision, ptosis, and limb weakness, presence of diabetic ketoacidosis, cerebral involvement of mucor, and development of CNS complications like stroke during the antifungal therapy were associated with increased risk of death. All patients who were discharged from the hospital were followed up for a period of 6 weeks to look up for late complications. These are the limitations of my study. Firstly, it is not a randomized controlled trial. Therefore, unmeasured confounding cannot be ruled out. Secondly, as for all retrospective studies, some individuals diagnosed with mucormycosis may be unreported, leading to a measurement bias and underestimation of mortality due to CAM. And unexplored factors, including genetic predisposition, were not identified. But despite these limitations, this retrospective cohort study adds to the growing body of literature and epidemiology, management strategies, outcomes, and long-term complications due to COVID-19 associated mucormycosis.
Thank you, Pranava. Excellent presentation. The topic is open for discussion.
Congratulations, Pranava. Very detailed statistical analysis, I would say. Very rare. You are an undergraduate or a resident?
No, I'm undergraduate. I just went to 3rd year.
Okay, so I'm very happy that you did such a elaborate statistical analysis. Okay, I just want to ask you, besides your steroids, anything else was the compounding factor for causation of CAM in the treatment protocol? You have listed so many options from treatment protocol. Can you name something very important, which was supposed to be one of the cause of causing CAM, especially in COVID?
The steroid usage and
steroid, I understand, yes.
The oxygen supplementation and even the iron supplementation which was given.
Okay. How would you elaborate about
antibiotics?
How would you elaborate about oxygen supplementation causing CAM?
Ma'am, I think
I think it's too much beyond your scope of knowledge and experience. I do understand, but you are doing so well, so I think you know it.
Ma'am, actually in this scope of study, we wanted to include a detailed analysis of that, but even Dr. Javed thought it was beyond my scope of study, but he did mention that hypoxic conditions were like the mask which they use, the hospital spores were not counted and all of those things.
Yeah. I think you have understood it.
Yes.
Maybe you're not able to articulate, but you understood what I'm asking to you. Okay, fine.
By the way, Pranav, I just want to know, because you are UG, did you see the mucor under microscope?
Yes, ma'am. Actually, I also a lot of data was not available on in the library, so I had to actually speak to a lot of patients as well and get files from them. So I did get to see a lot of patients, and Dravid sir also took me to the laboratory. And
because I understand mucormycosis is not a good thing to have, but this was also a study material available for you.
Yes, ma'am.
Yes, because you should have seen it under microscope, how it looks and what is the difference between the mucor and the other fungus. So yes, that was one study thing that you must have got benefited during this mucor. What madam was asking and what we all were thinking in those terms, being an ophthalmologist, I know we also dealt with many mucor cases, even in private. There were less number of mucor in first wave as compared to the second wave. And every time this question was asked why, but I must tell you, there were cases of mucor even in the first wave, though they were not so many reported. And there are many other reasons. As madam said, you are just a UG student and it is beyond the scope of your studies, but congratulations to you for a superb paper. And you are showing that research.
And one more thing I want to ask you, Pranava, this is the data you presented from Noble Hospital, right?
Yes.
Do you have any data from Sassoon Hospital? Was there any cases in Sassoon Hospital as well of mucormycosis?
Yes, of course, a lot of cases.
I think we have the largest series in India for COVID.
Yes.
So who stopped you from presenting Sassoon data?
No, actually, Dravid sir had offered because he actually needed help with all the data. So that is why I helped him. Otherwise, I would be in Sassoon.
Which operation theatre you have operated? Which operation theatre you have operated? COVID cases? Any idea? In Sassoon? Yeah, which was the operation theatre which was dedicated for COVID cases in Sassoon? Any idea?
Okay. No, I must tell you this point was, Dr. Surekha, this point was added from Sassoon people. When we were discussing a lot about and how to manage mucor cases, it was dental hygiene of many patients, which also were responsible for getting mucor cases or battle mucor. So we concentrated then onwards on oral hygiene, like what toothbrush and toothpaste they used during COVID wards were thrown off. They were requested to use another one. A lot of care, betadine goggles, even normal saline washes for nasal cavity. all that was done, and so the mucor came down, and it was a teamwork. It is always so. As a UG, you must get benefit of this. What we see in India, it's a learning.
And one more thing, we had lot of scarcity of oxygen during second wave.
Yes.
So in a hush and well, industrial oxygen was diverted, not oxygen, industrial oxygen, but the plant was entirely dedicated towards causing medical oxygen, I would say, production. So that was one of the reasons which was postulated, but not yet decided, that could be one of the reasons for some impurity causing spores. But that is okay, not yet
proved.
But that was one of the reasons. Yes.
Yes, yes. And another is de novo diabetes that we saw. We thought that the variant which caused the second wave had attacked the beta cells of pancreas, because the sugars were, even in non-diabetics, had gone up. So that could be another reason. But Dr. Surekha, there is a study in Gujarat where they have shown that 67% of mucor had never received oxygen supply during COVID treatment.
Yeah, that's true. That is why I said we cannot have a directly causal effect relationship.
Yes, yes. Any other question from other judges? We do, Pranava, take it very positively. We are not going to grill you. You are the junior most. But it's really, I'm feeling so proud that you just...
Exactly. I'm also very happy that she did it so confidently, actually.
Yes.
And such a complicated and vast topic.
Yes, definitely. And topic of interest. Yeah.
Yeah, just want to say kudos to Pranava. It was wonderful.
Yes, yes. 3 cheers to Pranava. Yeah.
Yes, yes. Okay. Heartiest congratulations. Should we go to the next candidate now? Dr. Abhinay?
Yes, ma'am.
You can share your screen, please.
Yes. Can you see my presentation, ma'am? Can you see my presentation, ma'am?
Yes, Dr. Abhinay, we can see your screen, and please speak a bit loudly and go ahead with your presentation.
Is it audible, everyone? Is it audible, everyone?
Yes, yes, it is. Please go ahead.
Good morning, everyone, and very thanks to IMA Pune for giving me this opportunity to present my paper. I'm Dr. Abhinay Vadlamudi, orthopedics resident from DY Patil Medical College, Pune. Today, I'll be presenting a paper which I have done like 2 months back on incidental identification of vertebral compression fractures in patients admitted under COVID-19 pneumonia unit using CT thorax. It is a retrospective cohort study. Coming to the introduction, as you all know, vertebral compression fractures are frequently asymptomatic. And unfortunately, these osteoporotic vertebral fractures are significant predictors of subsequent vertebral and non-vertebral osteoporotic fractures. The importance of the incidental identification of vertebral compression fractures in patients without back pain should not be underestimated, as it represents an excellent opportunity for the patients to become aware of the diagnosis of osteoporosis and to start treatment, which can significantly reduce the risk of subsequent further fractures. Incidental diagnosis is a valuable opportunity to identify low bone mass and to start treatment. As you all know, CT scan is more accurate diagnostic tool to identify and to characterize vertebral compression fractures compared with plain radiographs. And some studies have demonstrated that midline sagittal reformations of CT scan can be excellent instrument to detect the presence of vertebral compression fractures opportunistically. So in our study, we aim to determine the proportion of patients admitted under COVID-19 pneumonia unit in a single tertiary care hospital with chest CT scans, allowing visualization of the entire thoracic spine, who incidentally present as compression fractures. We initially evaluated 504 patients who underwent chest CT scans for COVID-19 pneumonia unit from July 20 to July 21. The criteria to consider a fracture as pathological were already described by Kubo et al. In their previous studies, where there is a destruction of anterolateral and posterior cortex of the vertebral body
and the destruction of cancellous bone of the vertebral body, and the destruction of end plates, and the destruction of the pedicles, a paraspinal soft tissue mass, and an epidural mass. And all the CT scans were obtained by a multi-detector 128 slice CT scanner Siemens. And following CT scan, the sagittal images were reformatted from axial images using bone windows. A section thickness of 1 mm was used to reformat the images, and coronal images were also available if needed. The CT scan was reviewed using the Siemens software tool PACS, which is available at our institution. Though it is done by me and a radiology resident, the senior author, radiology faculty also reviewed all the cases with fractures, either vertebral compression fractures or pathological fractures, to confirm the diagnosis and to classify the severity of fractures. It was already described by Gennant et al., where mild fracture is, that is grade 1. We classified it as grade 1, where there is reduction in the vertebral height of 20 to 25% compared with the adjacent normal vertebrae. Where moderate, which is grade 2, where the reduction is 26 to 40%, and severe, that is grade 3, which is more than 40%. And we also determine the percentage of these fractures described in the radiological reports, and we want to compare and how many have been reported and how many have not been reported. In our cohort study, we can see the median age was 53 years, where 31 to 91 is the range, and 63% were males and 37% were females. And a total of 504 patients, 76 people had at least one vertebral compression fracture. That is 15% of the total population study, where in the previous studies, the range varies from 12 to 25%. And 46 had at least one vertebral compression fracture, whereas 30 exhibited multiple vertebral compression fractures. And already, as I described before, based on the fracture severity pattern, 50 were mild, 15 were moderate, and 11 were severe. And the proportion is all 61% are males and 39% are females. And you can also see the age distribution, which I have charted here. More than 60 age group were more in this population, that is contributing to around 55.3%, and 50 to 60 were 21%, and less than 50 were 23.7%. And this is a table showing the number of patients presented with vertebral compression fractures, where I already told previously the 95% confident interval based on the previous studies was between 12.1 to 18.5, where we got here 15.1%. And patients with single level fractures were 69.7%, and multiple levels were 30.3%. And here I have described fracture pattern, whether it is single level or base and multiple level based on male to female, and which is insignificant based on chi-square p value. And as you all can see here, this is the compression fracture, which you can see here. And in the next slide, I'll show here how did we classify them. This is the vertebral I have taken the ratio. Based on the ratio, you can see that there is decrease in the there is vertebral compression fracture. Coming to the severity of the fracture, as I already told previously, 65, around 66% are mild, and around 20% are moderate, and around 14% are coming to the level of fracture. I have already made a chart level where T12 is most. Here we have taken only the thoracic vertebra into account, so T12 is the most. Wherein already in previous studies, T12 L1 is most common, T12, and in some sagittal CT reformats, we can also see the L1. So L1 is also taken into account. Coming to the discussion as such, among the factors that may explain the underreporting of ECF using chest multi-detector CT scans, it is likely that as spinal age-related findings are extremely frequent, radiologists consistently report vertebral compression fractures only if spine scans are requested. However, they may left unreported if they are not relevant to clinical questions, that is, just CT for assessing CORAT score and staging CT scan in a patient with terminal metastatic cancer or acutely sick patient from an ICU. Our results show that almost 1 in 6 patients over 60 years old undergoing these scans with or more vertebral compression fractures. And these data should prompt radiologists and clinicians evaluating patients undergoing multi-detector CT, also abdominal and pelvic CT scans obtained for any reasons, even without a present history of back pain, to actively look for vertebral compression fractures, especially in elderly age group. Furthermore, physicians evaluating chest and abdominal and pelvic CT scans should be aware of their important role detecting incidental vertebral compression fractures, independent of the primary reason to request the study. Coming to conclusion, an important proportion of the patients over 60 years old evaluated with just CT presented vertebral compression fractures. The reporting of these vertebral compression fractures is insufficient. Only 10% altogether in total 76%, total 76 patients out of 504 had vertebral compression fractures. Only 10 of them are reported. Less than 10% have been reported, which we can see that only the severe fractures have been reported in their reports. So in this period of pandemic types, many patients are unable to come to hospital. So careful evaluation and inclusion of even minute fractures in reports and explaining the risk of subsequent fractures when they have been admitted for COVID or and treating accordingly will minimize the risk of subsequent fractures altogether. These are my references. Thank you.
Thank you for an excellent presentation. My colleague would like to ask you a few questions. Yes.
Hello, Abhinav.
Yes, ma'am. Yes, sir.
Yeah. After finding the fracture on CT scan, have you done MRI or bone density, DEXA scan for these patients?
No, sir. Actually, it is a retrospective study. So all the patients who are admitted in COVID unit previously, based on their CT scans, irrespective of the purpose, mostly it would have been done for CORAT scoring actually. So based on that, we have taken, the questionnaire is how many patients of these are reported actually. Only 10% is being reported. Only 10 are reported of the total 76. So we want to.
In those reported patients, was the MRI or DEXA scan done?
No, sir. It was not done, sir. This is a retrospective study. It was not done, sir.
Not done. Okay. And in those detected patients, what was the treatment given for those vertebral compression fractures?
No, sir. Previously, the patients were admitted for COVID. It was a retrospective study, so we want to enlighten the situation that this vertebral compression fractures are very common, and using the chest CT, which was done previously for COVID and CORAT scoring, can be used to classify.
So you want to give a message to radiologists that while reporting for other things, you also look and report for the vertebral compression fractures.
Yes, sir. Though only severe fractures are reported, even mild and moderate fractures can be reported, and which can even it can also suggest that the patients are having a risk of osteoporotic fractures in future.
Okay. So last question. Those mild fractures which went undetected or underreported, had they been reported, what would have been your treatment protocol?
So treatment protocol would be.
For your mild incidentally found fractures, what would be your treatment?
So we would further like to investigate the patients based on the. We would like to go for the calcium profiles. So we would go for their vitamin D levels, renal function test, and calcium and PTH levels. Based on them, we would assess the patients, and based on that, the treatment would go. Ultimately, mostly it would be metabolic, sir, mostly in many patients. So we would start on vitamin D, 6 lakh international units IM, or we can give 60,000 international units weekly ones for 12 weeks.
By default getting vitamin D.
Yes, sir.
Okay, thank you.
Just a question. I mean, this is about the clinical. I understand that you're a radiologist, right?
No,
I mean,
ma'am. I'm an orthopedic, ma'am. I'm an orthopedic.
Okay. Okay, fine. So this was a chart review. You said that you did retrospectively, and it was about picking up, fractures.
Yes.
What is the clinical implication? I mean, it is for both orthopedics and for radiologists. If you were to sit and, why did you do this retrospective? The chart review at all? One is, of course, as you said, that it is missed. So this is something that you could look into.
Yes, yes. And one more.
I mean, why did you think about?
Yes, sir.
Yeah.
Ma'am, I thought many patients are not coming to hospitals these days. Mostly elderly patients are not coming to hospital these days. And during COVID times, when they are admitted, if they know about the burden of osteoporosis and if at all they were, if they have known the.
I was more interested as to why you took up the COVID patients. Is it like because there was CORAD scoring which started getting done, and HRCTs that we started doing much more, and in fact I think it was being done for almost every patient, even if not indicated or not in the SOP actually. So was that reason that you picked up? You sort of wanted to do this chart review, or it is like you would also suggest that probably elderly patients who have not been very mobile, just as we advise, like, once a year medical checkup, is this something that you would advise? Because it's also about, advocating a particular, the clinical implication would be something that you would use the study for something in future, apart from, of course, treatment implications and, ruling out low vitamin D or, supplementing, whatever.
One more thing would be, there are many diagnosed cases of back pain also actually in elderly patients. So getting a CT scan and reporting these mild compression fractures also would actually be part of a diagnosis in future.
No, but why I asked is because CT exposure is again about radiation. So as Sir was asking, was DEXA scan advised? Is that something that is, much better to do in terms of, looking out for, a potential fracture in the future, and then, like actually going, preparing a SOP, for example, for ruling out, mild fractures in the elderly population.
Actually, ma'am, the DEXA scan nowadays does not. It is indicated as previously, but nowadays the CT-based L3 Hounsfield unit, less than 120, many studies they are taking into account, and less than 90 Hounsfield units also they are taking into account. If it is less than 90 Hounsfield units, which I have not included in this study, I'm doing it one more study, ma'am. Less than like it is an indicator for osteoporosis also.
Doctor,
thank you.
My question was, were you able to differentiate?
Can I ask something?
Dr. Sharma is asking.
Yes,
so after, Dr. Sharma, go ahead.
Were you able to differentiate between old and new fractures on the CAT scan? Because for all you know, these patients may have already had a diagnosis of osteoporosis and old fractures that now you're catching. So would there be any differences on imaging to differentiate between those?
Yes, ma'am. The imaging old and new, we can certainly not differentiate, ma'am, if it is very mild actually, and if it is very severe, we can differentiate whether it's old or new.
So then that leads me to my next question. Since this was a chart review for the patients that you did see the fractures in, were you able to go back and look if they had a diagnosis of osteoporosis already or were on treatment for it?
So we can look into that, but we haven't taken that since it was the data. Our main objective was to ring a bell in the mostly the treating clinicians and radiologists to report more of mild and moderate fractures. So we haven't.
Okay. Dr. Shinde, madam, your question, please.
Thank you for this presentation. I will like to ask you from anesthesiologist point of view. Are there any similar studies which are done across the world, similar data presented with same findings? Have you come across the literature search?
Yes, ma'am. There were similar 2 or 3 studies, ma'am, which were done previously, and they have used both CT thorax and CT abdomen also, ma'am. As T12 and L1 are most commonly prone to vertebral compression fractures. They have used both, which is the limitation of this study actually. It was there. There are studies, and they have also used. They have also. Yes, ma'am. Hello. Yeah.
Yes, Dr. Shinde, madam, you can complete your sentence.
Am I audible?
Yes, now you can.
Because we are giving regional anesthesia for unfortunately, especially in old age group. So unknowingly, we might be missing out on those fracture cases. So can you all suggest at a larger scale some guidelines for screening of such patients? So for that, we have to have a bigger data, you know, pool data and data studies, you know. So I would suggest go ahead with your orthopedics and radiology. So we can get some guidelines, and especially it is the orthopedic ones who are very reluctant for getting our patients investigated because they are in a hurry to get operated. So this is a good guideline to screen these patients at the stage. Yeah. Asymptomatic, because all these patients were asymptomatic as far as the symptoms are concerned, you know, and it's a very, I would say, very vital parameter, fracture, and it might be attributed medically for post-operative outcome, especially when we are giving regional anesthesia. That's why it turned my anti. So we will also look at this in my arena also. Thank you so much.
Thank you
for enlightening and giving us awareness. Yeah.
Yes. Should we go to our next candidate now? She's Dr. Ayesha Chaturvedi. Dr. Ayesha, I think you have already shared your screen.
Yes. Good morning, ma'am. Am I audible?
Yes. Go ahead.
Okay. Good morning, everyone, all judges. My name is Dr. Ayesha. I'm presenting a rare pneumonia in an immunocompetent adolescent, which was actually diagnosed to be pulmonary nocardiosis. So as an introduction about nocardia, the species are branching filaments of gram-positive bacteria, generally omnipresent in soil and water. And there are a total of 50 species of nocardia, out of which 16 have been found to be causing human infections. And the most commonly seen in terms of literature as well as history, and what we read is that nocardia infections commonly arise in the immunocompromised states. For example, like organ transplant patients or patients of leukemia, patients with HIV or steroid abuse, long-term steroid use, and autoimmune diseases. And the main manifestation of pulmonary nocardiosis is pulmonary because of the inhalation of airborne spores and fragments from environmental sources. So, and this is also again usually seen in immunocompromised patients. So here we had a case which you want to report, which was a case of pulmonary nocardiosis in immunocompetent patient, and the age group, which was adolescents, which is generally not known to be associated with immunocompromised state. A 13-year-old male with no comorbidities presented with history of fever, breathlessness, cough with streaky blood tinge expectoration for the last 2 months. He had no chest pain, wheeze, loss of appetite, or loss of weight. On examination, he was febrile, mildly tachypneic, normotensive, and mildly hypoxic as well. General physical examination revealed right supraclavicular lymph nodal swelling measuring 3 to 4 centimeters. On examination, that was soft, mobile, and non-tender. Respiratory examination revealed signs of consolidation in the right upper lobe. Rest of the systemic examination was normal. His routine blood investigations revealed leukocytosis with neutrophilic predominance and non-reactivity for HIV. We were trying to rule out all other causes that could explain his symptoms. His chest radiograph revealed right upper zone consolidation. Contrast enhanced computer CCT of thorax showed a necrotizing right upper lobe consolidation, as we can see in the right lower figure, which measured 8 into 5.4 into 7.5 centimeters with heterogeneous peripheral post-contrast enhancement. Our differentials at this point were number one, tuberculosis, because of the burden of disease in our country and the typical presentation of an upper lobe consolidation, which was cavitating. Apart from that, we also considered fungal infections, and malignancy was in our differential, but much lower down on the list. Sputum was sent for gram staining, which only revealed gram-positive cocci. Along with that, we did sputum examination for tuberculosis, including ZN stain, KOH mount for fungal infections, gene expert, liquid culture, and solid culture with LJ media, all of which were negative and showed no growth. The UHD neck was done, which showed a right cervical lymphadenopathy, and we even went ahead with aspiration and FNAC of that, which was suggestive of reactive lymphadenitis. Subsequently, CT thoracic biopsy was done, transthoracic lung biopsy, and we sent that for an examination. On HP staining, it was revealed to just show neutrophilic inflammation with no evidence of malignancy or tuberculosis. Now that we had to start ruling out other causes and go into more rarer causes, we went ahead with the fiber optic bronchoscopy, which was done and showed purulent discharge from the right upper lobe bronchus. Bronchoalveolar lavage for gram stain revealed typically gram-positive, dotted, striped, fine, right-angled, thin branching filaments, which showed both bacillary and coccoid elements, suggestive of nocardia species. We went ahead and got a culture on sheep blood agar, which showed a chalky texture and minute aerial hyphae. Ideally, we went ahead and then when it was inoculated in Middlebrook media, we saw no opacification, hence effectively ruling out tuberculosis. We did an antibody susceptibility test for the nocardia, which was sensitive to cefotaxime but resistant to tobramycin and erythromycin. This indirectly pointed out that it was nocardia asteroidis complex. A scan of the brain was also done to rule out intracranial nocardiosis, and that was normal. We even did serum immunoglobulin levels to rule out CVID, or combined variable immunodeficiency syndrome. But all the immunoglobulin levels, IgG, IgA, and IgM, were all normal. The patient was diagnosed as a case of pulmonary nocardiosis and started on tablet trimethoprim 160 mg with sulfamethoxazole 800 mg once a day. And he showed gradual clinical improvement over 4 weeks of treatment, followed by significant radiological improvement at 6 months. The X-ray on the right is at 6 months as compared to the left side. So there was significant resolution radiologically. We continued the treatment for 1 year as per protocol to avoid relapse. And currently he is asymptomatic since the time of completion of treatment. In terms of discussion, the points I wanted to highlight was initially that nocardia or a nocarditis infection is not very, very high up on the list of our differentials and generally presents itself with very similar tuberculosis-like symptoms like fever and cough and breathlessness, which does not respond to broad spectrum antibiotics. And in this case, we have seen multiple other cases also in the literature, which has shown that these patients generally are given empirical ATT, and when they don't respond to it, then further investigation is done, which leads to a certain amount of delay in diagnosis and treatment. The CT findings that we found in nocardiosis in our case was, again, we only had capillary consolidation. And according to literature, this is generally very, very variable and has pleomorphic findings in terms of CT imaging. The initial presentation, again, as I said, was very suggestive of pulmonary and cervical lymph node TB. There are overlapping clinical radiological findings as well, but we ruled it out effectively with BAL and with sputum and FNAC examination. Ideally, we should have gone for molecular testing via 16S rRNA and HSP65 gene specific primers. However, there were financial constraints in the case, and we went ahead with indirect identification by conventional culture, which proved indirect identification of the species was Nocardia asteroids. We also had to rule out disseminated disease because in cases where the infection has traveled to the brain, causing intracranial nocardiosis, then it requires a more aggressive treatment approach of 2-3 months of IV antibiotics. And hence we ruled that out with a CT scan of the brain. In most Indian case series that I have searched upon, patients who had pulmonary nocardiosis either had two of the following conditions. Either, as mentioned before, they had an immunocompromised status, or they had a chronic lung disease like COPD or bronchiectasis. However, in our case, there was no pre-existing lung disease. He had immunocompetent status, and he was of the adolescent age group. The duration of treatment we had given was according to protocol for a minimum of 6 months, and we extended up to 1 year to prevent relapse till for after symptoms of infection had been resolved. We closely monitored the patient as well, which is essential to detect relapse following the cessation of antibiotics. We went ahead and gave him sulfonamides and trimethoprim as is the first line therapy. And the response is very, very favorable with no serious adverse effects. Thank you.
Thank you, Dr. Aisha. The paper is open for discussion. Over to you, judges, for the questions.
Dr. Aisha, I don't know, maybe I missed it in your case, but once you had the diagnosis of pulmonary nocardiosis, did you go back and look for other immunocompromised conditions like diabetes or HIV or chronic?
Yes, ma'am. I mentioned non-reactivity for HIV and all lab investigations were normal. I'll just go back to that. So we even did the serum immunoglobulin levels to rule out CVID, because that was the only other explanation we could have, that this patient had a genetic or a childhood situation of an immunocompromised state. But there was no lab investigations revealed anything apart from a mild infectious leukocytosis with neutrophilic predominance, and HIV was negative.
So do you have a theory for why this patient presented with as bad a case of pulmonary nocardiosis as he did?
Ma'am, I feel that now maybe with changing antibiotic resistance patterns and with changing infectious epidemiology, I think that it is now becoming more of that we should not look only in immunocompromised states when we come to these rare infections. The way the burden of tuberculosis is also increasing, maybe we have to look and expand our differentials when it comes to patients even who are apparently immunocompetent. We still need to consider fungal infections and these rare kind of infections that are not normally seen, atypical kinds, even in patients who don't really present the same way. And of course, differentials for tuberculosis can be multiple, and this should be given high priority in the list as well.
Okay, thank you, doctor. It was an excellent presentation. Any other questions from other judges? Meanwhile, I must tell the participants that your certificate of participation in soft copy format you will receive by email. You can have the printout. Those who need it for their MUHS submission can very well do it. This conference has been approved by MMC, Maharashtra Medical Council, so you can submit those certificates to MUHS.
Thank you, ma'am.
Further questions from judges?
Hello, Bhavna. Can I hear you?
Aisha, yeah.
Yes, ma'am.
Am I audible?
Yes.
Yeah. I just want to ask you, is it possible to have mixed infection in such situation clinically?
Clinically, yes. In fact, there are other cases, obviously, when they went ahead with more cultures of the bowel and sputum, they did find other organisms for which, again, antibiotics were the course of treatment. But a lot of cases came to us and which were reported, which came to us with non-response to ATT and broad spectrum antibiotics. So that was when we started to look for other causes of it. So yes, mixed infections are common. But then with general broad spectrum antibiotics, those could get resolved. But nocardia, being a specific kind of infection and organism, requires a more specific kind of therapy.
Is it only respiratory infection it causes, or any mixed symptomatology?
No, it can also cause cutaneous nocardiosis, which is also very, very common. But that is also, again, does not come to us that often, more than dermatology, of course. But yes, cutaneous, pulmonary, intracranial, as well as intestinal infections of nocardia have been reported. which are then defined as disseminated nocardiosis.
Okay. Any endemic preponderance for this infection?
No, ma'am. In fact, that is why we were, I would like to say we were in denial that this could be something apart from tuberculosis because of the very typical presentation of a lymph node swelling and a right upper lobe consolidation. But as of now, ma'am, in the literature search that we have been seeing, these immunocompetent cases are very, very uncommon, especially in India. There are some cases reported outside also, especially in Switzerland and France. But there again, immunocompromised states, because those countries are developed, as well as chronic lung diseases like COPD being a prerequisite for that kind of infection to really set into the body.
Thank you, Dr. Aisha.
Thank you, ma'am.
Can you stop sharing your screen, please?
Yes, ma'am.
Dr. Dipti, if you are able to screen share your presentation.
Yes.
Dr. Dipti, we missed her because she could not do it. And after that, there would be Major Ankit Kumar, Dr. Ramnath Kundage for his poster. I am not seeing Dr. Anagha Gole and Dr. Priyanka Savarthi and Dr. Sanjay Gandhi as participants. Dr. Ashish Arbat, what is your presentation? I have not yet received from you. So I request these three people to contact me on a personal chat. Dr. Priyanka Savarthia, Dr. Anagha Gore, and Dr. Sanjay Gandhi. And right now we go to Dr. Dipti, whose presentation was remaining. Dr. Dipti, kindly share the screen with your presentation, please. Dr. Dipti, if you are taking time, may I go to Dr. Major Ankit Kumar, please? Sir, can you share your screen, please?
Am I audible, ma'am?
Yes, yes, you are audible. Please share your screen. Dr. Dipti, you please keep your presentation ready after this.
Is my screen visible, ma'am?
Yes, it is visible. Please go to your... yeah, now it's fantastic. Go ahead, sir.
Good morning, everyone. I'm Major Ankit, Dr. Ankit, resident medicine. I'll be presenting my paper titled The Psychological Impact of COVID-19 Among Newly Diagnosed Patients, COVID Impact Study. We all know that COVID-19 pandemic was one of the worst pandemic which has hit the mankind in this history. And India was the second most affected country worldwide. And the COVID-19 clinical manifestation of COVID-19 has been varied across all over the study. However, the psychological manifestation, which was not very obvious, has studied in very limited centers. So the psychological impact of COVID includes fear, stress, frustration, anxiety, even depression, panic behavior, desperation, hopelessness, and even adverse outcome like even deliberate self-harm. And also, there were multiple stigmas associated with the COVID-19, and the word like COVID-19 survivor and Corona warrior also add to the psychological impact of the illness. And following the post-recovery from the COVID, and there was also high likelihood chance of post-traumatic stress disorder component in the patients. So we planned this study because majority of the study were carried out by online survey before this study, and there was no study done in at the height of the pandemic, at the peak of the height of pandemic in our country. So this study was done to assess the psychological impact of COVID-19 among the newly diagnosed patient of study. So my study was a cross-sectional observational questionnaire-based face-to-face interview carried out at a tertiary care hospital in Western Maharashtra over a period of 2 months at the peak of pandemic. Institutional ethical clearance was taken, written informed consent was taken, and relevant history regarding demographic profile, COVID-related symptoms was taken according to pre-tested and pre-validated questionnaire. And data on psychological impact was collected using impact of event scale revised in the patient language which they understood. And the statistical analysis of the data was done using SPSS 22.9. We included all adult patients with age more than 18 years and who were newly diagnosed, and diagnosis was confirmed by RT-PCR for SARS-CoV-2, and patients who were willing to participate in study and they gave consent. And the only mild to moderate cases were included because severe cases were already admitted in the hospital and they were oxygen, so they were not included in the study. And the patients who were requiring oxygen were not included. However, healthcare workers were also not included in this study because there were many studies done on the healthcare workers. So we did not include healthcare workers, and it may bias, so we avoided including healthcare workers. So this was the impact of event severity scale questionnaire, which had 22 questionnaire, and each were self-reported. It is a self-reported questionnaire, and patient graded their symptoms on 0 to 4 scale of 0 to 4. So based on symptoms, it had impact of psychological impact was assessed, and it was either minimal with score 0 to 23, mild with a score of 24 to 33, moderate 33 to 36, and severe with score more than 36. And also it had subclasses like intrusion, hyperarousal, and arousal skills. So mean of all the skills were mean of the sub skills like intrusion avoidance and hyperarousal were also included. The patient were also asked about few factors like day-to-day factor which affected them most, like risk of infection to the other family members, loss of their job, children education in the COVID pandemic, inability to fulfill commitments, and other economical losses. So now coming on to the results, we included 150 patients in the study. However, 14 declined to participate in the study and 9 entries were missing. So we had 101 patients in the study. The demographic profile, clinical features, and score IS was included in the study. So we classified our patients in the age group. Majority of patients were in age group 18 to 40 years. With the mean age of our sample was 40.4, and there were only 3 patients who were aged more than 75 years. There were male preponderance with 83% cases, and majority of patients were educated up to high school. And there were no patient in the who were educated up to postgraduate. Employment status, majority of patients were self-employed, and only 10% cases were homemakers. Now clinical profile was also collected. So patient with commonest symptom in the patient was fever, followed by cough, and breathlessness was reported in only 8.9% cases. And 31% cases had underlying medical conditions, and 23% cases had contact with COVID-19 positive cases, and only 5.9% cases has recent history of travel. However, none of them had history of international travel. Now, as per the response impact of event scale revised, 31% patient has minimal, and a similar amount of patient had severe psychological impact on them, and approximately 19% had mild and moderate psychological impact. And the mean of intrusion scale was 9.7. However, avoidance scale was maximum with mean of 10.89%, 10.89 score. We also correlated various demographic and clinical profile with the impact of event scale score. However, the only factor which was significantly correlated was age, and age as the age progressed, there was significant higher psychological impact. However, the history of contact, history of recent travel, and other symptoms of COVID-19 were not significantly associated with the psych score. As we can see here on the scattered plot, there was positive correlation of ISR scale with increasing age. So now coming on to the discussion, our patient in our study, there were 31% patients who had severe psychological impact, which was higher as compared to the initial survey conducted online. This may be probably because as the pandemic was growing, there was increased coverage of the increased coverage of the news about the various aspect of the COVID-19 and the lockdown and other effects. There was we all know that this in this pandemic we had majority of the patient had mild illness, and they have significant impact around significant psychological impact, which was large chunk and which may affect their day-to-day life and their mental health. Elderly with comorbidity, as their age was increasing, they were at risk of increased psychological adverse effect. And we found in our study that the clinical symptoms were not significantly correlated with ISR score. And the respondent in our study had mild to moderate illness. This could possibly explain the dissociation of clinical symptomatology and psychological scores. The limitation of our study is that the healthcare workers were not included, and majority of patients were young included in the study. However, elderly who were not coming to this was an OPD based study. So generally elderly were admitted in the hospital, so they were not part of the study. And psychological impact were not correlated with the lab parameters and other radiological features of severity of COVID-19. So what this study knew, this was first of its kind with a face-to-face interview directly on OPD basis in the newly diagnosed patient of the COVID-19. And we found that elderly with increasing age were more at risk of adverse psychological impact, and there was need of integration of mental health services for mild and moderate COVID-19 at the peak of the study, which after that this was implemented and multiple steps were taken to reduce the impact of COVID-19 on mental health. So I conclude by saying that COVID-19 has definitely increased the adverse psychological impact in various groups of people, especially in elderly. And we propose that mental health services must be integrated in care of COVID-19 patient. And those patients who has demonstrated a severe or moderate response to COVID-19 infection may warrant intervention and follow up further to look for post-traumatic stress disorder. And other multiple studies has been done and were required to be followed up to look for post-traumatic stress disorder. These are my references. And I'd like to thank my patients and the relative for participating in the study, all my teachers and IMA and MULTICON for giving opportunity to present this paper. Thank you.
Thank you. Thank you, Major Sir. Excellent presentation. Over to you, all the judges, for the questions, especially to Dr. Jyoti Shetty.
Yeah. Thank you, Dr. Ankit. I was very interested in hearing your thing. Was there any inclusion of any psychiatry?
No, ma'am. We did not include
in terms of
any...
preparing the protocol.
No, ma'am. We did not include any psychiatric patient in this issue. We only took mild and moderate cases who came for giving their RT-PCR report, and once their report came positive, they came for the follow-up, and they were on the follow-up initially for first time they came to OPD for initial checkup, and they were on the follow-up for home-based care. So we've taken those patients only, ma'am. Psychiatric patients were not included in this study, ma'am.
No, I was not talking about psychiatric patients. I was talking about mental health professionals being included in preparing the protocol.
Yes, ma'am. Yes, ma'am. One of the co-author was Colonel V.S. Chauhan, sir. He was the psychiatrist, ma'am. He validated and he was helping us out, ma'am.
Okay. So what was the intervention done? Because you said that 30% of, though it was an online survey, 30% did have severity of symptoms, and they were also on OPD basis. So what was the attempt at, sort of giving them some sort of, I mean, of course, you all prepared a SOP of integrating mental health services later, but that was an added on which came out of the study. What was done for the patients who you already saw the 30%? Yeah.
Yes, ma'am. Initially, once we had initial report in the late November, December, then we started implementing like small things like yoga and speaking, allowing and guiding patients whosoever seeking any loneliness or any abnormal things. We welcomed them to speak to us, and we integrated them to. Initially, we advised them to watch YouTube videos for yogas, and we kept them yogas and keeping themselves busy at least, because they were lonely most of the time. So small things and follow up we took for any adverse things, and we kept in contact with them after every third day, fourth day. On telephonically we followed up.
Why I'm asking is because AFMC itself, sort of presented guidelines for non-pharmacological management for people dealing with COVID. In fact, it was presented on most of the WhatsApp groups actually, and of course Nanan's also had come out with a book.
Gradually that increased, and then gradually it was taken up further, ma'am. So online classes, yoga classes, and many other things, ma'am.
Yeah.
Can I ask?
Yes, ma'am.
Yes.
Can I?
Yes.
Yes.
A very important, I would say, presentation, and it's up to the interest of the Shetty madam, because it's a topic of her heart. But I would like to ask you, was any use of WhatsApp university protocols used as one of the question? Because I am not having any idea whether the questionnaire was validated, but because of the scare what we had in general public regarding COVID was mainly because of wrong WhatsApp messages. Was there any questionnaire regarding that also? I want to ask.
Ma'am, as initially before we conducted our study in September, October. Initially before that study, many WhatsApp online surveys were conducted to assess the mental health and awareness of patients about the COVID and how much they had psychological impact. But as such, in our study, we did not had the same question whether they were previously assessed, and we did not include any question in this question, ma'am.
What was the score? Which was the score used to assess psychological upset?
Ma'am, this question, this is this question IES scale is revised IES scale, ma'am. Okay. This assesses the after an event, this assesses the stress and how much amount of psychological impact on the patient is there. Yes. So IES revised.
I understood that, but one of the conclusion is that mild COVID is related to more of psychological impact. So how can you relate to this finding?
Ma'am, conclusion is like mild COVID was majority of patients were mild cases. 85 approximately 85% burden was of mild cases. So total amount will convert to more of mild cases, because severe cases were already admitted. So we can counsel and directly they were in contact with the doctor. So mild cases were not in the contact.
So you may not be having this correct inference, because the whatever data you have collected, the sample size mainly consisted of the mild, isn't it?
Yes.
So
Yes, ma'am.
This is something about which is the little compounding factor. You should have equal percentage of having mild and moderate. Then only we can come to this conclusion, because otherwise patients who were having home quarantine, mild diseases, they were quite okay, and the moderate who had oxygen, who were admitted with a very unknown surrounding, they were having more of a psychological impact. That's what we have come to the conclusion. So this, I think, needs more elaboration.
Right, ma'am. Right.
Yeah.
Thank you.
Thank you.
We have now two more presentations. One is by Dr. Dipti, who could not present. If you are ready, Dr. Dipti. After Dr. Dipti, it will be Dr. Rangnath for his poster presentation. And after that, Dr. Sharma has requested he will be presenting his. Apart from this, any participants who wish to present, please contact me on my personal mobile number or on my email. Dr. Dipti, please go ahead with your presentation. Go to the slideshow.
Visible, ma'am?
It is visible, but not in slideshow. It is,
Yes,
you can present slideshow and
yes,
your voice is audible.
Yes, ma'am. Thank you, ma'am. I'm sorry for the earlier interruption. This is my thesis topic also, ma'am. The topic is the effect of music therapy on quality of recovery in patients undergoing abdominal surgery under general anesthesia, a randomized control trial, and my faculty is Dr. Kaminder Bir Kaur. I'll be covering the topic under the introduction, objective, methodology, results, conclusion, and the references. Coming to the introduction, music is an old form of expression, even older than language. Music's application have expanded with human evolution, including therapeutic application. With the introduction of psychoanalysis in the 20th century, music therapeutic value as a non-pharmacological, low-cost, safe technique was fully realized. Individual social, mental, physical capacities are restored, maintained, or improved using the soothing effect of music. Several neurophysiology research investigated the scientific basis of music therapy effects with the result of establishing some evidence, particularly on the effect of music on hormone secretion and nociceptive reflexes. People's physical and emotional tension can be reduced by listening to the music. This personality trait has been widely researched in attempt to draw medical benefits from it. Music therapy has been shown to be beneficial in a variety of conditions like dementia, depression, cancer, stroke. It has been found to be excellent pain and anxiety reliever and accentuation of conduction in afferent fibers, mnemonic encoding, stimulation of endorphin synthesis, and the influence of psychomodality are all part of the
You, Dr. Dipti, we cannot see your second slide. This first slide, you are stuck with the first slide because now you are not in the slideshow.
Yes, ma'am. I'll just just a second, ma'am. Ma'am, is it okay now?
Yeah, still you are not in a slideshow, but this is introduction slide we can see.
You're seeing only introduction slide, ma'am. Ma'am,
now is it visible, ma'am? There is a slideshow option on your PowerPoint. You just go up, there is a slideshow option. Click on the slideshow and click on the slide, whichever you want to project, and start from there.
You can click from current slide, no? So it will go forward. Then you have to just keep clicking. Yeah.
Ma'am, is it okay?
Yeah.
Yes, ma'am. Thank you, ma'am.
Okay, you can click one by one slide. So right now we are seeing your introduction slide. You can click the next slide, please. Slide number 5. You go to slide number 5 now.
Ma'am, this is the slide number 5, ma'am.
Okay, then go to 6.
Ma'am, this is the slide number 6. In the study, we want to see.
I think there is a delay between.
See, there is slide view. So you know. Can you call someone to slideshow?
Yes, ma'am. Yes, ma'am.
It's on the taskbar down, you know.
Yes, ma'am.
Of that point. There is an icon. Hi, yes.
Yes, now it is correct. Now
yes,
just,
thank you, ma'am.
Just present it. Yeah.
Yes, ma'am. Music is a non-invasive and safe adjuvant that can improve a patient's overall perioperative experience. Surgery and anesthesia offer unpleasant experiences for the patient, and they can cause tension and worry, which can prevent patients from achieving their therapeutic goals. Music therapy has been exclusively researched for its potential to improve perioperative outcomes with conflicting findings. Preoperative, intraoperative, and post-operative music therapy regimes have been described in the literature. Intraoperative music therapy was reported to be considerably lower pain severity during the recovery phase among the recovery. In this study, we want to see how efficient intraoperative music therapy in reducing the discomfort, maintaining hemodynamic stability, and ensuring a smooth recovery from anesthesia. In addition, one of the most common and the serious perioperative mistakes is awareness during the general anesthesia, which could be improved with music therapy. The aim of the study is to evaluate the effect of music therapy on the quality of recovery in patients undergoing abdominal surgery under general anesthesia. The aim of the study is to determine the effect of music therapy on quality of recovery in patients undergoing abdominal surgeries under general anesthesia. The objective is to find the difference in the quality of recovery in patients undergoing abdominal surgeries under general anesthesia with and without music therapy, and to compare the VAS score after awakening following the surgery between the two groups. The study was conducted in FMC Pune after approval from the institution ethical committee. It was conducted on 106 patients, which was divided into the two groups, and all adult patients scheduled for abdominal surgeries under general anesthesia was included in the study. It was a randomized control study and a double-blinded study. The inclusion criteria was all the patients scheduled for abdominal surgery under general anesthesia, which were aged more than 18 years with ASA 1 and ASA 2. And the exclusion criteria was any emergency surgeries, cognitive or psychiatric disorders, hearing and impairing disease, chronic treatment with analgesics, patients not extubated immediately after the surgery or who has been shifted to ICU following the surgery, and patients who denied for the consent. The methodology was in the pre-operative room. Earphones was attached to the patients to know the volume of the music comfortable to the patient and allowed to choose the music, which will be remain same throughout the study period. The patient from the OT list meeting the inclusion criteria was randomized into the two groups, Group M and Group C. Earphones were applied to the patient, but the music was only started in the patients who has been randomized into the music group. In the operating room, patient will be connected to the standard monitoring and the baseline parameters were noted. And the pre-medication was done with the injection pental at the 1.5 mics per kg and glycopyrrolate 200 mics. After pre-medication, earphones were attached to all the patients and the music was played only in the music group following the induction. And anesthesiologist was played in the patients who have not given any choice for the music. Induction was done with the injection propofol in the dose of 2 milligram per kg, and the patient was intubated with the atracurium 0.5 milligram per kg, and anesthesia was maintained by the sevoflurane with a mixture of 50% oxygen and the 50% air, and the music was maintained throughout the surgery to the end of the intervention. And the patients were reversed with injection neostigmine 50 mics per kg and injection glycopyrrolate 10 mics per kg, and after awakening, during the tracheal extubation, recovery quality was observed by the Ricker sedation agitation scale, and the patient was shifted to the post-operative. Along with that, VAS score for pain was checked after awakening from the surgery, which will be marked at the end of the surgery, at the end of the study. This is the Ricker sedation agitation scale, which scores from 1 to 7. The score of 1 is unarousable, the 2 is very sedated, 3 is sedated, 4 is calm and cooperative, 5 is agitated, 6 is very agitated, and 7 is dangerous agitation. We divide it into two groups, less than 5 and the more than 5. The statistics was done by chi-square test, and the p-value less than 0.05 considered statistically significant. The demographic parameters were comparable in both the groups. We have included the different kinds of surgery like laparoscopic cystectomy. Most of the patients were from the laparoscopic cystectomy patient, around 40% patients, and other surgeries was left adenyx and mass staging laparotomy patients. And the results we have got in the VAS score, we have divided into the three group, less than 3, 3 to 6, and the more than 6. And we have got a statistically significant value of 0.05 in the music group. The VAS score was much lesser in the music group, and the maximum case VAS score was 3 to 6. And the Ricker agitation scale, the p-value we have got is 0.01, which is statistically significant in the music group. We have got the calm patients following the surgery with Ricker agitation scale of less than 5 in the music group. Coming to the conclusion, music therapy is an innovative approach that has proven effectiveness in many medical conditions and is beneficial also in managing surgical patients, even those operated under general anesthesia. This simple, non-pharmacological, inexpensive, and non-invasive technique could significantly enhance patient satisfaction and decrease the awkward experiences of the patient related to the perioperative stress, pain, and awareness. Most studies, some of which are of considerable scientific power, advocate for the implementation of intraoperative music therapy in the treatment protocols. Thank you. These are the references. Thank you so much.
Thank you, Dr. Deepti. The topic is open for discussion. Something different.
Yes. Can I?
Yes, yes.
Thank you, Dr. Deepti, for this musical experience. I have 2-3 questions to you. Actually, which kind of music did you use? Is there any correlation between vocal or instrumental or classical, semi-classical? Was there any study about that?
Ma'am, actually, during the most of the cases were the elective surgeries, ma'am. So during the pre-ops, when we go to the patient, I used to ask the patient regarding the choice of their music. So around 40% of patients have given their choices for the music. Most of these are coming from the Maharashtra, so they have given the Marathi music, which they used to listen usually. And in the 30% patient who have not given their choices, so I have played the instrumental music, ma'am, for them.
Okay. And one more thing, this is more of a scientific concern. Was there any study of depth of anesthesia intraoperatively?
Ma'am, actually, I tried to do it for the 20-odd patient. I was able to do it, but because of the COVID pandemic, I have to move on the TDs for the other places. So I could not continue it. I did only for the 20 patients, ma'am. And in these 20 patients, what I could make out is in 50% patients, ma'am, the depth of anesthesia and the requirement of the volatiles were reduced, ma'am.
No. Actually, I want to ask you reverse way. Was there any correlation between the intraoperative depth of anesthesia and the subsequent VAS score post-operatively? I mean, what was the average depth of anesthesia you had managed to keep for all these patients? Because that is one of the compounding factors, especially.
Yes, ma'am. Ma'am, the 20 patients which I could make is, ma'am, between the 40 to 60, ma'am. Usually BIS score.
Okay, okay. Yes, good. Yeah. Thank you. Thank you, Deepti.
Yeah, stop sharing your screen, please, Dr. Deepti, and we go to our next presentation, Dr. Rangnath.
Yes, ma'am.
Thank you so
yes,
much,
ma'am. Am I audible, ma'am?
Yes, you are audible. Please share your screen.
Yes, ma'am. Is it visible, ma'am?
Yes, it is visible. Please go to slideshow.
Yes, ma'am.
Yes, yes. Please go.
Good morning, ma'am. Good morning, panel. I'm going to present a poster in MULTICON 2021. I would like to thank the team MULTICON and the judges panel. My topic for today's presentation is daytime sleepiness in type 2 diabetes mellitus patient in Indian population. It is a cross-sectional study. Ma'am, this is my poster. Now, background. The diabetes mellitus is one of the common chronic medical conditions which affects approximately 347 million people worldwide. And in India, we have known that it is becoming a giant, and 72 million people are affected across the India. The studies have shown that up to the 1/3 of patients with diabetes mellitus, they suffer from sleep disorders. The wide range of complications which occur due to diabetes mellitus, these are responsible for the poor quality of sleep in working population. And this poor quality may lead to the poor quality of the life of that individual. The complications may include nocturia, nocturnal hypoglycemia, peripheral neuropathy, restless leg syndrome, sleep disorder in breathing. The daytime sleepiness is also a risk factor for hypoglycemia and the depression and obesity. My study aims to compare the daytime sleepiness in type 2 diabetes mellitus patient, particularly in the Indian population, As I have come across, there are certain Western studies in which they have given emphasis over the sleep and sleep medicine. But the very few studies are in Indian continent. My study design, the study design is cross-sectional study. The study population comprising of the patient who are reporting to a tertiary care hospital in Southern Command Hospital. And these are the diagnosed cases of type 2 diabetes mellitus as per the IDF criteria and its update till date. And I have particularly chosen the age group 40 to 60 years who could be at working somewhere. The patient with type 2 diabetes mellitus, the total number is 17. They were given the Epworth Sleepiness Scale and are the same Epworth Sleepiness Scale is compared with that of the individual who are non-diabetic patients. The patient who are bedridden with some complications, severe hypertensive cases, and various sleep disorders, night shift workers are specially excluded from the study. The data was analyzed with the optimal measure by applying Mann-Whitney test. This Epworth Sleepiness Scale is a questionnaire-based study, which is a pre-validated questionnaire. The study is done in Australia, in Epworth Hospital, and it is a subjective measurement or subjective score of a tendency of individual to fall asleep. There are certain questions. There are total 8 questions and in different situations, which depict a particular score. When there is no chance of dosing, we give a score of 0. Slight chance, we give a score of 1. Moderate chance of 2, and high chance of dosing is 3. The total square will comprise of 24. And depending upon the score of the individual, we categorize the individual into when there is no absolute chance of dosing, average, excessively sleepy, and the patients who are required absolute medical sickness for their treatment for the excessive daytime sleepiness. The study included 17 patients of type 2 diabetes mellitus and 17 control as a non-diabetic case with age and sex matched individual who are voluntarily participated in this study, and written informed consent has been already taken. The Epworth Sleepiness Score in diabetic patient is 7.2. Sorry, ma'am. The mean Epworth Sleepiness Scale in diabetic group was 70.2, and in control group it is found that it is 2.7. And there is a statistically significant difference is been seen in daytime sleepiness with type 2 diabetes mellitus patient as compared to the non-diabetic patient. Now, finally, to conclude, the study shows that the type 2 diabetes mellitus patients are more likely to support the daytime sleepiness as compared to the non-diabetic participant. And I would recommend it is important for a healthcare provider treating the diabetes patient to address their sleep issues and inadequate fragmented sleep, as it may severely affect their recovery as well as the control of the diabetes in his quality of life, to improve the quality of life of that individual. These are my references, ma'am. Thank you, ma'am. Thank you, panel.
Thank you, Dr. Rangnath. The poster is open for discussion. Over to judges for the questions.
Dr.
Yes, ma'am. Yes, ma'am.
Yeah.
Who's asking? Can I?
Yes, Dr. Jyoti. Go ahead.
Yeah. Okay. Dr. Rangana, thank you for your presentation.
Yes, ma'am.
Very clearly and lucidly presented.
Yes, ma'am.
Just a few clarifications. Now you have taken, the study group being type 2 diabetes,
yes,
and the control group being non-diabetic, match for age, right?
Yes, ma'am. Yes, ma'am.
So what about other parameters? Like, since you are using Epworth Sleepiness Scale, what about
yes,
parameters like obesity in
yes,
both the groups? One, because you have mentioned in your background that daytime sleepiness is a risk factor for hypoglycemia, depression, obesity,
yes,
and especially when we see that patients with, for example, obstructive sleep apnea,
yes,
obesity, have been known to have a lot of daytime somnolence because of their
Yes,
poor
ma'am.
quality of sleep at night.
Yes, ma'am.
So was that something that you ruled out, because your inclusion exclusion criteria was one line, so it was not very clear
Ma'am.
as to if there's one thing. And then secondly, you also, I mean, since I wanted to just finish the questions, you also said that they had diabetic patients had a poor quality of sleep. So when you spoke about the study including diabetes mellitus patients,
Yes, ma'am.
what was the status of their diabetes in terms of blood sugar control? Because it is known that when they have basically a nocturnal nocturia and frequent getting up for the nocturia, they would be having disturbed sleep anyway. So I mean, and especially if they were not very well controlled diabetics. So what was the control? I mean, what is the patient population sample that you took in terms
Yes,
of
ma'am.
control of diabetes, in terms of obesity and their BMI?
Ma'am, as I would like to answer your first question, ma'am, that this is actually, I am presenting a poster for daytime sleepiness, and it is a part of my thesis, ma'am, one of the part of my thesis. I have already collected the demographic data, which will be statistically representing in my thesis. Here, I have just compared the non-diabetic and diabetic Epworth sleepiness scale, ma'am. And the diabetic itself is one of the factor for the sleep and wake cycle of the sleep, and the orexins are considered to be the responsible factor, which are there for the influence of the sleep. Regarding the status of the diabetic patient, all the patients who are coming to the OPD, then I search for in wards also, but their diabetic control, they are the well controlled diabetic patients, ma'am. Actually, there are very few patients who are having diabetic the blood sugar, their fasting and PP more than 200. But as of the patients are already taking metformin or their anti-diabetic drugs, their sugar is well controlled. I hardly see a patient who is having HbA1c value more than 8 or 10, let's say, ma'am. So these are the things, if I clear your doubts, ma'am.
So, Dr. Raghunath, I do think that
actually,
you need to include the obesity portion and control for that.
Definitely,
Because,
ma'am. I'm taking BMI also, ma'am. Yes, ma'am.
right. So even on this poster, because just saying that the ESS score was higher in the diabetic group, it could very well likely be compounded by the fact that the BMIs were higher and there was undiagnosed or untreated obstructive sleep apnea in that group. So I think you should include that when you do the statistics,
Yes,
and you might get some different results.
ma'am.
Yeah.
Yes,
Hello?
Shinda. Yes.
Actually, it is again a repetition of question. All three judges have pointed out the same question. I think even for a perioperative, as a perioperative physician, I would like to know about obesity, BMI, because that is the main factor of having daytime somnolence, OSA. So this diabetics directly cause daytime or the obesity. I mean, this compounding factor should be ruled out. I suppose so in further studies. It is one of the best predictor. The way.
Yes, ma'am. Yes, ma'am. Definitely. Yes, ma'am. Definitely. I'm taking this in my thesis, ma'am. For the same thing, ma'am. And I will definitely, the sample size in my poster is, ma'am, 17. Actually, that may be one of the limiting factor. I am definitely increasing the sample size. The sample size in my base article is around 112. So that may be a significant variant, ma'am. It will definitely improve my study.
Okay.
Ma'am.
Thank you, Dr. Ramnath.
Yes, ma'am.
You can stop sharing your screen. We come to our last presentation now. Dr. Sharma is there.
Yes, good morning, ma'am.
Yeah, good morning. He has requested to present his poster. Dr. Sharma, you need you to present your poster.
Yes, ma'am.
But you need to register for the conference so
I
that
will,
I
ma'am.
can get your certificate.
Yes, ma'am. Right after the presentation, I'll do that, ma'am.
Okay. Request to all judges to have your scores and send to me by email or on WhatsApp number by evening, Indian Standard Time by evening. For Pranjali, you can send me anytime. And we'll be declaring the results tomorrow morning. And the winners would be informed and they would be getting their certificates and awards from the award function here tomorrow at IMA physically. I also request Dr. Surekha Shinde madam and Dr. Jyoti Shetty madam, you are kindly invited to IMA. We would like to felicitate you, and Dr. Pranjali Sharma, personally I'll come to you to felicitate you because you gave your time to for IMA for judging this session. So over to you, Dr. Jaiman Sharma. You can share your screen and start presenting your poster. Anybody else who is otherwise, this is our final poster.
Yep. I'm just sharing the screen, ma'am. Factor for sustaining future falls and subsequent fractures in geriatric patients. So we as orthopedic surgeons, we advise various lifestyle modifications to reduce the risk of sustaining a recurrent fracture in this vulnerable group. However, we have discovered over time that patient adherence to the modifications which we advise has not been documented in any previous study. So in our study, we aim to evaluate the patient compliance and subsequent adherence to these lifestyle modifications so that the future fracture risk in this vulnerable population, which is one geriatric, is increased. So ma'am, for this study, we took 112 patients, which were geriatric, that is aged more than 65 years, who already were diagnosed as having a peritrochanteric frigidity fracture of the hip, that is IT fracture, intertrochanteric fracture, and subtrochanteric fractures. They were treated operatively for the same, so we included those patients in this study. Upon discharge from the hospital, the patients were advised that 10 lifestyle modifications. We gave them a paper, a chart with 10 modifications to reduce recurrent fracture risk. These modifications mainly included like using anti-skid flooring at their houses, hiring some personnel to take care of them, or we asked them to modify their houses and install railings and all of that to improve the lighting condition in their houses. All of these factors, but we gave them 10 modifications, and we also gave them a data collecting form which graded the adherence on a 20-point scale. We gave 2 points to each factor, so 2 into 10 was 20. Upon the 6-monthly follow-up visit of these patients, adherence was assessed on the 20-point scale, and data was collected via face-to-face interview. We called the patients back for a follow-up, and then we collected the data. So statistical analysis was accomplished by chi-square test and logistical regression analysis. When we observed the results, ma'am, we observed that out of the 112 subjects which we included, 51.7% was male, and the mean age was 75 years, 75 plus minus 8 years. And most of the patients in our study adhered to less than 4 recommendations, which was a score of less than 8, which was 39.2%. Around 30% of the patients adhered to 4 to 6 lifestyle modifications, and around 29% patients adhered to 8 to 10 recommendations. So according to regression analysis, we discovered that less than 6 recommendations, the patients which followed less than 6 recommendations, which pretty much comprised 68% of our total study group, were coming from low socioeconomic strata. And this was implicated on lack of education and lack of awareness. So in conclusion, we concluded that the rate of adherence to the advised lifestyle modifications were generally found to be low overall, compliance was particularly reduced in patients who belonged to lower socioeconomic strata, which were less likely to be educated and had lower rates of income. So we concluded that merely advising these lifestyle modifications to reduce the fracture risk was not enough to stop the menace of recurrent fragility fractures in this vulnerable population group. Like Western countries, for example, the NHS in UK and the United States, in India, there's an urgent need to institute social security and public health measures. For example, in the NHS, they conduct regular follow-up visits at home to see if the patient has actually incorporated those modifications in their lifestyles. In India, we do not have any such methods in place. So to reduce the future fracture risk, we need to institute social security and public health measures to improve patient adherence. So that was our conclusion with this study. Thank you.
Thank you, Dr. Sharma. And the poster is open for discussion or any questions from judges.
I commend you, Dr. Sharma. It was very interesting to listen. And then I think coming from psychiatry and mental health, we have a lot of things that, we need to operationalize. Yes. And I love the way that you have operationalized something like lifestyle recommendations, yes, to study that and the impact of that, and then done regression analysis to actually, done a multiple regression analysis to actually get some sort of finding. Something that we obviously see, because poverty or low income groups are the ones, it's not because they don't wish to, but it is the non-adherence is because they can't afford to. Yes. So it was very nicely and scientifically done. I commend you for the methodology that you have followed. Apart from that, what was your take-home factor in terms of, now you know that, it's statistically significant, in terms of publishing, but then the thing is, how would you sit and, further proceed, if you were to put in policy measures or even in terms of education of patients? Poverty is not something, there are lots of factors which are not in our hands as doctors. Yes, yes. But what is that you could do in terms of improving their own care?
And what we've realized is in orthopedics, we don't have certain methods to institutionalize this. Like, for example, ma'am, when we look at ophthalmology as a branch, or when we look at gynecology and obstetrics as a branch, the public health services at the PHC level, the Anganwadi workers, the NMMs, they have a very active role in going to the patient's houses at a very grassroots level, at the last mile population level. And they go and check the implementation of these measures. When it comes to orthopedics per se, patient-sustaining fractures, for example, these methods are not really in place where those Anganwadi workers can actually go to somebody's home and see what methods or what measures have they taken, improving the flooring, for example, anti-skid flooring. In India, we can't advise anti-skid flooring, but at least we can advise some sort of cushioning on the floor. So all of those methods, the take-home message from this entire study was to actually go to Anganwadi workers or at the last mile population and tell them to maybe play an active role in looking into this problem, like they do, for example, with the orthopedic, with the obstetrics and with ophthalmology. So that can be done. That is one take-home message.
Any other question? Yes.
Yeah. German, I think this problem is mostly related to psychiatric aspect, actually. Shetty madam has rightly pointed out. So are there any conclusions or any findings related to psychological status of the patient in that old age group? For example, old people staying in a family, staying alone, or loss of, I would say, a partner. Are there any study about this lifestyle management which can compound to this non-adherence to the protocols?
Ma'am, we tried to include what you just said. You rightly said that that is a problem in the lower socioeconomic group. We try to include that angle where the old people are living alone or they don't have the support of their children. But sadly, ma'am, in the modern society, we discovered even in the patients coming from upper socioeconomic strata, even most of them were living alone. Their children had moved out to different countries or maybe different places in the same city. So they didn't have, no doubt, lower socioeconomic strata also have, along with nobody to take care of them, they also have less finances. The people from the higher socioeconomic strata have the finances, but it is not really a given that they will also have support of their children or social help or public health. So we could not really include that in the study, but yeah, you're right, that could be included somewhere. But sadly, even people coming from good families, let's just say, sometimes don't have the support system around them. So we could not really include that or put that into words somewhere.
Thank you.
Thank you, Dr. Sharma. It was an excellent presentation.
Thank
and
you.
I would take this opportunity to thank all three judges for taking such active interest in each and every paper and each and every poster and putting your own inputs and asking details about that. So the students were excellent as well. And I also appreciate the students and their guides for these papers and posters. It was a wonderful session. And as an IMA representative, I feel very, very proud about these young students who are taking interest in research along with academics and their post-graduation. As IMA has decided, I would once again repeat, those PGs or UGs who need any kind of help in research methodology can contact us, and we can, contact you to research experts on our panel. One of them, Dr. Pranjali, has already agreed to help our Indian students for their international presentation or international publications. So you can take help of IMA for doing this. Saying so, it was a wonderful session. Dr. Jyoti Shetty, Dr. Surekha Shinde, thank you very much. I again invite you tomorrow to IMA. And thank you, Dr. Pranjali Sharma, for joining. I know it's late night over there in the US.
Thank you. Thank you.
Thank you. Thank you so much. Thank you, ma'am.
Thank you very much.
So only one poster, Dr. Sharma?
Yes, ma'am.
There were two posters. One was by Rangnath and one was by Dr. Sharma, last one. Because another poster he presented as a paper.
Okay.
Okay, he presented as paper, and Priyanka Savarthi and Anaga Gore have requested not to present. They could not present today. And Dr. Sanjay Gandhi is not contacted, so his paper is not included. Rest all
Sanjay Gandhi is the same senior Sanjay Gandhi?
Yes, but he...
My classmate?
Yes.
My classmate.
And his son was, I think, Dr. Pranjali Sharma's batchmate.
Yeah. Okay. Thank you, Dr. Gitanjali. It was wonderful being part of this.
Yes,
Actually.
my pleasure. My pleasure. All of you joined. It was a wonderful session. Thank you very much.
Thank you. Thank you. Thank you. Thank you.